हेलो डॉक्टर साहब। गुड आफ्टरनून। अच्छा, ये बाकी स्पीकर्स ने ज्वाइन नहीं किया? नहीं, पहले तो डॉक्टर गौर का है ना। हाँ, तो उससे पहले नहीं ज्वाइन करेंगे? अर्जुन जी की अगर वो पहले
Arjun sir, Ravi sir is not there.
Vidiji, can I request you to come online now?
How are you? Hi, sir. I'm here only.
Good afternoon.
Good afternoon, sir. How are you, sir?
Very good, very good. I think yesterday we had a very good level of participation at with Tide 2021, and I think we should look forward to another successful day today. We
Yes.
have a host of eminent speakers coming on board, and I'm quite optimistic that things will be better today than they were yesterday. So,
That will be, sir. Don't worry.
so we should start in about 2 minutes. आप start करिएगा, then I will follow the procedure program as per the schedule program.
So after 2 minutes, we'll start our main
Yes,
program, right?
2:05 exactly.
Okay, fine. Okay, fine. Uh, so first of all, welcome you all. It's a very good and new day for all of us because we are going to study a lot going to study a lot about diagnosis. See, there are a lot of things which we can do. I don't know how many of you are doctors, but if you are not a doctor, if you're not a medical person, then you cannot realize their hard work. So we should give them a lot of love, care. Seriously, as as we have listened last day, all the topics were very good. But I found one thing only. Arjun sir, I found one thing only last day that was it's quite hard to be a doctor than an engineer because we have.
I'm also an engineer and an MBA, but yes, being a doctor is way tougher. Let me be very honest
Yeah,
about it.
actually, it is very tough to be a doctor because they have to do a lot, and as we have time to do, like ऐसा हो सकता है ना, we can say I want to take one more day. Like I was there in Kevadia to see our Sardar Vallabhbhai Patel statue. The engineer said, we have taken 46 weeks, 46 months for this only. And they did a very big task, but they said, okay, we can take 1, 2 more days for that. But if doctor said to me that you are in trouble and I want 1 more second, I cannot give him. I have to say only
I'll
that
give
you
you
have
another
to
point
wait
of
for
view,
time.
Miss Jane. I'll give you
Yes.
another point of view. If an engineer says, I'm going to take 3 months extra to build this project, you get very upset. But if a doctor says, I will give you 3 months extra to live, you get very happy. Big difference.
That's a positive attitude towards life. Yeah, that's good. So, no, doctor can give us anything actually. He can give us anything. Seriously, this pandemic we have seen, uh, like I can say, I have seen doctors, I have seen God in the form of doctors. Because when I went with my mother, like, and I said, please inko bacha lijiye, and doctor said, don't worry, I'll do. And he did. So I can say I have seen a God in.
Well, okay. I think it's good. We've got Dr. Ravi Gaur with us also. Dr. Gaur is welcome, sir.
Good afternoon, everybody. Pleasure to be here.
Sir, Ms. Jane is our moderator, and my name is Arjun Mahajan. I will be I'm DGM Sales and Marketing here at J.Mitra. So we will be interacting during the course of this session. So, Ms. Jane, let's start the show. Dr. Gaur is here, and he's our keynote speaker for the day. Right. So, okay, I think Ms. Jane is experiencing a slight technical glitch. No worries. I'll take it away from here. Don't worry. So, respected panelists, participants, a very warm and hearty welcome to day 2 of Tide 2021. This is the second edition we have for Tide, and it's a path-breaking digital conclave dedicated to our medical diagnostics industry. The COVID pandemic over the last 1.5 years has shown us, in fact, it's ushered in many changes. One of which is the fact that we have gone from shaking hands to saying namaste, even more, right, in the name of social distancing. Zoom and Skype and another web-based platforms are another big change that have come in, and they have enabled us. I look at technology here as an enabler. They have enabled us to go forward. They've enabled us to kind of look at interactions in a different manner. Now, J.Mitra is very pleased to partner with all stakeholders, be they organizations such as Mila, medical practitioners such as Dr. Gaur, Dr. Jain, Professor Ratan yesterday, among others. The aim here being to bring you the latest and updated discussions, presentations on the field of medical diagnostics. We had a very eventful day yesterday, and I'll take another 5 minutes to kind of run a brief synopsis on day one of TIDE. We started the day with a small discussion by Professor Ratan from Pathkind Labs, where he encapsulated future technologies that were being looked at, future directions in the field of medical diagnostics, and how we were moving from sick care to healthcare, from reactive to preventive diagnostics, from reactive to preventive medicine. I mean, he took us through a series of slides and a series of examples, whereby he really brought out the future trends of diagnosis, how we're getting miniaturized, how tech is an enabler, how we're going from from sick care to healthcare. So Dr. Ratan showed us the light in the light at the end of the tunnel ahead. Following that, we had some serious discussions with Dr. V. Ravi from NIMHANS in Bangalore, who is also the nodal officer in Karnataka for genome sequencing. Now, Dr. Ravi took us through some of the key points in terms of the problems faced at the lab level for COVID diagnosis, be there PCRs, be it rapid tests, the kind of difficulties faced with the lab and the solutions to those particular difficulties. Following that, we had a very interesting panel discussion moderated by Dr. Suchitra Jain. Dr. Jain had a set of eminent panelists with her, including Dr. Neeraj Jain from Milap, Dr. Rahul Kamble, Dr. Sharma, and Dr. Padma Srikant. They were faced with the challenge. The questions that she came up with were specific to COVID, in how the world healthcare industry, how the healthcare sector has been affected directly with the advent of COVID-19. Dr. Jain had some very pertinent questions, and the panelists brought out their answers in an even more clearer fashion. There were talks about how the new development of Omicron, how Omicron is coming into the and how it is spreading. What are the key things to look out for with respect to Omicron? We talked about how using good quality testing, especially whether it be PCR or rapids, is critical to getting the right diagnosis. We talked about input on trainings and how the training industry, especially the medical training industry, has shifted gears. It's undergone a paradigm shift in the last 1.5 years with the advent of the COVID pandemic. And of course, there was Dr. Pradeep Sharma, who had a lot of theories which backed up by data, where he spoke about infection in the pediatrics, infection in children with respect to COVID-19. Our last speaker for the day yesterday was Dr. Surasnata Das, and she was faced with the not so enviable task of comparing rapid tests and rapids and PCRs as a means of COVID diagnosis. We all know that rapids will not match PCRs, but there are certain applications that rapid tests have, which in certain situations can be quite useful and give speedy results. They may not be the best in terms of specificity, but given the testing algorithm that ICR employs, it was her understanding that rapid tests and PCRs could coexist in the testing sphere. That being said, we threw a lot of light yesterday on COVID, but today I think we've got a set of varied topics coming up, and I would like to hand it over to Dr. Miss Vidhi Praveen Jain I'm sorry, we mistake everyone for doctors here, right? Yes, let's
Thanks
get
for calling me doctor, sir.
Ms. Jain, over
It's
to
a
you.
pleasure for me. Okay, thank you, sir. Actually, I would like to say one line of Orpa. Orpa said, "Passion is energy," and we met yesterday, and I found that you are passionate, you are energetic at your life and at your work also. So that was very good, Doctor. Sorry, again, Doctor. A lot of doctors are here. Thank you, Shri Arjunji, for your words. Very nice and very good words. And as you said, yesterday we learn a lot, and today we are going learn a lot of things again towards our life. If you are from medical industry, you will understand everything. But as me, we can understand the things which we need to understand during our life. Now, I'm gonna to start today's session. Good afternoon, everybody. My name is Vidhi Praveen Jain, and I'm your host and presenter today. And warm welcome in TIE 2021. And again, we are here with a good discussion with the actually Arjun Mahajan. As Arjun Mahajan said yesterday, we did a great job, and today we are going with our new promises. So, today we have Dr. Ravi Gaur of Spice Health, who will talk about emerging trends in diagnostic and vector borne diseases. Then we have Dr. Padma Shrikant from Sri Ramchandra Medical College and Research Institute, Chennai, will focus on dengue updates for 2021. We'll go with Dr. Smita Shivade from Jariwala Laboratories and Diagnostics, Mumbai. We'll talk about current practice and challenges in the field of vector-borne diseases like the leptospirosis, dengue, and malaria. Then we will go with the flow of Dr. Upasna Mamble from Adesh Institute of Medical Science, Bhatinda, will shed light on recent advance in malaria rapid antigen test versus microscopy. So all the speakers will be answering your questions, but for that you have to put your question in the chat box and they will answer you. If we cannot give your answer as time will list, then we will mail you your answer also. So please put your questions in our chat box. So for the session one, we are going and we are focusing on emerging trends in diagnostic and vector-borne diseases. We have speaker Dr. Ravi Gaur, is a well recognized in the healthcare circuit, an MD in pathology. He is principal advisor Spice Health and founder of G Path Labs. He is also a chairperson of Health and Wellness Committee at CII Delhi. Now, I'd like to call Dr. Gaur, sir. Stage is yours, sir. Please, sir, come and give some suggestions, give some knowledge related all the health issues. Please do come, sir. Dr. Ravi Gaur.
Good afternoon, everybody. I think, and welcome to this highly, the knowledge-based and the new thought-based forum, where I think what we are really working is whatever the conventional wisdom and what is going to be the future, probably combining the two and making sure the best of healthcare, especially the diagnostics, is available to the in the current scenario. And as we gear up for the future, we're ready to prepare ourselves. I think I'm thankful for the organizers, Jatin, and Jun and everybody, and in fact, of course, the J.Mitra. I think this is something which is an event because we have heard a lot of industry events, what's really happening in the business here and there, but something which is technologically sound, which is a knowledge which is actually required to apply on the ground for the laboratories, and it means for the what it really means for the clinicians. I think this is a wonderful forum, and I'm really thankful to the organizers and pleasure to be here. I think I'll straight away come back to, in fact, yesterday's session, and I've attended one of the few sessions, and they were really interesting. And so I was really wanted to talk on some of the emerging trends, but many of them have been covered yesterday because that's exactly said today. Probably the two different verticals of diagnostics are coming up. One is, of course, the wellness, and second is the illness. Because there are now preventive health is going up, going up, and going up. And at one point of time, we all thought like infectious disease are over. Now we are talking about NCDs, and we're talking about cancer, cardiovascular disorders, obesity, and other things. But I think COVID has seen us know. They reminded us infectious disease are going to be there, and we should be prepared. And especially in infectious disease, there can't be a time lag. You need to diagnose the disease ASAP. Otherwise, it can be fatal. And this is, I think, the learning. So probably we have to come back to the the infectious diseases, and one of the common we have in India, of course, in the tropical countries, the vector borne disorders. So I'll be touching my topic today with two important things. One is, of course, the emerging trends in pathology diagnostics. What's really happening in the pathology industry? That's fair have been discussed yesterday, but I'll just touch on so that we are ready for the vector-borne diagnosis and application of these trends and as we move ahead. I'd like to share my screen, or I think, Arjun, you have my presentation. I can't hear you.
You can share your screen, sir.
Okay, 1 second.
I've given the rights.
Now, you can see my slides, please.
Perfect, sir.
Okay. So with this, I think I just move on from here. And I think one of the first thing I like to really see today, what's really happening, the pathology actually. The spectrum of the pathology industry, if you look into it, on the one side, if you see there's a current, uppers is currently, there are basically, we have central lab, we have regional labs, we have primary labs, and some amount of point of care testing is happening, near patient testing is happening. So the central labs are become a more of a referral lab, super specialty labs. Then the hospitals are more into the regional, where have the primary and secondary testing, which is required for the TAT-based 24 hours or 48 hours. Primary labs, of course, 24 hours of same day testing, and point of care immediate testing. But with the future gaining, I think what's really happening is all these even central labs or the hospital labs are growing faster. They are becoming more of a referral labs now, and they are adopting best of the technologies. I think this is something which is the change which is coming to pathology lab. So maybe the OPD diagnostic labs like ours, they're really to gear up to cater to, and what's really happening in the hospital. Hospitals have understood the important diagnostics. So they are, something very gearing up for the best of it. Up to the bigger hospitals have got even NGS, molecular, sequencing, studies, and everything is right up there. But on the other side, we have a home care, we have a on-the-spot care, rural care, immediate care. So more this has been stretched. One side, we have point of care testing, near patient testing, which is fast reporting as early as possible. So what was earlier the esoteric, which was probably done in a remote setting or referral lab some years back, now it's become actually on the spot a primary care, like a thyroid hormones, even some the cultures. So especially the infectious rate today we are seeing, talking about COVID itself, people want to do a COVID PCR report in instant 15 minutes, 20 minutes, 30 minutes. This is where really the whole spectrum is changing. We need to be gearing up. So, but then the newer labs or the bigger labs, or central labs are gaining technologies. On the other side, primary and secondary is the game of numbers and the turnaround time. This is the first thing which is really happening in the pathology industry. Now, second, if you move on, which is, Dr. Ashok Rathan, in fact, has been mentioned yesterday, that it is from treatment of illness to aggressive promotion of wellness. I think this is another area. Now, we are now, today, in fact, today, for that matter, we were all like, whenever anybody had symptom, used to go to a doctor, used to prescribe test, and after that, the technician used to come to us. But now with the COVID, actually, the science center is fairly bound to change. I remember in my labs, we used pathology centers, we used to only get 5 to 7% of people coming for preventive checks. But today, the number has gone up to 18-20%. That's a big number. Now, why this has happened? Because people are now aware of importance of diagnostics and the prevention. If you can know in advance that you're likely to be having or you're predisposed to particular disorder, disease, you can take care. So that is, I think the change is really happening today. So we have, the wellness is coming, playing a very, very important role. People want to come for early diagnosis, predictive diagnosis, preventive diagnosis, and of course, even the prognosis. If somebody already has, let's say, cancer, treatment has been done. Now, when is the relapse going to happen? What point of time will happen? I think this is another area which is probably, and the lifespan has increased now. The NCD, people are age is almost like 80 years of thing in the urban settings, even rural urban setting. So the NCD is 65 to 80 years of age. More number of people who have non-communicable disorders, and they are exposed, and they want to be well. Even if they're having hypertension or having cardiovascular disorder, they want to feel well. So preventive health check is definitely going up, and we are definitely going into that phase. Now, the another thing which is really happening in the industry is the molecular diagnostics. Molecular, genomic, DNA, RNA, everybody is talking about, from womb to tomb. I think its application is growing from end to end, right from NIPD, even the conception, infertility, from there to the entire pregnancy. Then what happens is the personalized medicine, which is applicable to oncology and cancers, then lifestyle disorders, even it's something everywhere, even up to the, you can say, the autopsy is part of it. The molecular diagnostic is growing, and applications are growing at very, very fast. On that, what better example can be COVID, where we have seen actually the common man now knows about RT-PCR, RT-PCR, RT-PCR. In fact, they just come to our lab and say, do you do RT-PCR? That's it. They don't know what RT-PCR, COVID, or what. They want to do RT-PCR, they think is a test. And that's a technology which is awareness. I think molecular, it's a real importance today. And it has proven its worth, credibility. I think we are definitely, heading toward that direction. So that is something, another thing which is this is now the healthcare revolution in making. I think we'll probably say rapid change is becoming a defining feature of pathology. We have to keep working towards adoption of new technology. Otherwise, you'll be lagged behind. We have point of care testing, we have molecular pathology, the nanotechnologies, biosensors, epigenomics, digital pathology, artificial intelligence, everything is being applied together. The whole application and have to be now brought into the labs and put together with the use of information technologies. And that is where IT is going to play a very important role. So I think that's where the entire pathology industry, if you're looking today, entire pathology is heading for technology, which is actual technical platforms, advanced technologies, which is getting miniaturized and faster, rapid, molecular genomic level, illness and oriented, wellness oriented, new wellness biomarkers, early diagnosis, and of course, integrating them all together. That's what I want to talk about. The diagnostic centers are now going to be more of an integrated diagnostic centers, and they're soon going to be reality. Now, integration means that today, we go for a health checkup. And once somebody goes for a health checkup, they go for a blood test or X-ray test. But if it's not the blood test, because 5 people can have the same kind of a blood reports, but one develops a cardiovascular problem, another develops some other disease, 3 don't. What is there? There have to be some other factors. So genomics is one factor. Your lifestyle, your environment you come from, the culture, what you eat. I think the whole preventive health check, and of course the clinician judgment, because I think all put together, that is by use of artificial intelligence or data algorithms or machine and IT. And this is where I think we're getting a more, we have to integrate all the findings together and come out with a personalized risk score for a wellness, for that matter, or a very personalized precision medicine. They call it more of a companion diagnosis, for that matter. I think this is an area, and for that, I think pathologists need to be definitely more of a clinical solution provider. They need to be coming in front of the microscope, not really sitting behind. They need to interact more. Radiologists have already done that part. They are interacting with the patient. They are interacting with the clinician. Pathologists are still far behind. I think we need to really work on that. And if you really join hands with the clinician, I think we can really provide a good moment to the diagnostic, our clinical friends. And of course, patients are demanding more. I think they want to talk to you more. I think that is where another area. So all IT can solve the issue. Everything probably connected together with clinicians, patients, our diagnostics equipments, and our diagnostics technicians and pathologists. I think that's going to be a integrated diagnostic center a reality in future. Now, last, I think the another area which is we are seeing is the emerging trends here is, I already mentioned about it. Basic lab testing is moving out. It's moving to point of care now. Though many advancements happen in point of care. Somewhere way back, we have some sugar and pregnancy, but now today we have almost point of care right up to hemoglobin, to blood gases, the cardiovascular markers, and even for COVID now we have the instrument from various the rapid PCRs, even for a rapid infection kind of a thing, but tuberculosis, everything has become almost like a point of care. So then the new sample type people are looking for. COVID taught us again the challenge. It was something like how do we transport blood samples? So probably they were more of a body fluids, tissue, and saliva, anything which is at ambient temperature, which can be transported. So I think this is something which is really, these are the trends which are emerging. And of course, the look into this, it's like current diagnostic is intermittent. We pick up samples in between 1 month, 3 months, 6 months. It's like trying to watch a movie, I said, but it's seeing it every 20, 30 minutes, especially when say patient is admitted in ICU, every half an hour you do some analysis, but in between you're missing it out, actually critical part. So it's really becoming a current diagnosis is becoming a continuous kind of a thing. That's where we are. We have a bedside reactivity, movable and portable. Inside our epidermal electronics, tracking deliveries and intermittent. So they are all tracking you and they're giving you alerts and alarms at wherever you are. So I think these are the few trends which we are want to see as we move future and diagnostics. As a pathology labs, we need to be ready to integrate and adopt this in our practice. With this, I move on. The current topic is this background. I move on to the topic that advancement of vector-borne disease in diagnosis. I think this is a mosquito, maybe a small bite, but I think the biggest threat is today is mosquito. That machar chota nahi samajhna. We really have to think like that's something. It can do wonders. It has done wonders. It's creating havoc. It can create havoc. Now, what are the vectors? I think if you say vectors are living organisms that can transmit infectious pathogens between humans or from animals to humans. I think between the human beings and from animals to humans, these are this vector. Now, many of these vectors are what they're blood-sucking insects, which ingest disease-producing microorganisms during a blood meal and from an infected host, and later transmit it to a new host. Probably they bite at one place and then they go to another human being and even animal, and they infect the other person, and the disease develops. And often, once a vector becomes infectious, they are capable of transmitting the pathogen to multiple people and for the rest of their life, or even subsequent bite. And these are the vectors, and that's the biggest problem today, which has really come up very, up again for that matter. Then what are vector-borne diseases? Actually, this is what I defined as a vector. Now, vector-borne diseases are human illnesses caused by parasites, viruses, and bacteria, and transmitted by vector. Various diseases can be caused. I list them out as we move forward. Then some data say that more than about 700,000 deaths annually from vector-borne diseases. This is a big number. And we need to be really aware of it. It's been like science has been there for a very long time, but still we have not been able to probably diagnose early and take care of that. It's a major epidemiological problem. It's a major one of the problem in all the hospitals, on all the especially remote areas or some geographies of India, even Africa, and worldwide in many places. So in recent years, we've seen the emergence of the vector-borne disorders. Like you have seen, dengue keeps coming in and out. Zika, we have seen. Ebola, we have seen. And they keep coming again and again. Something is coming up again and again. In fact, we had some point of time something, a plague which was something, a rat bite, which something which was coming up long back. The Japanese encephalitis is already endemic in certain areas. So and they are coming with a rapid pace and with different picture today. So it's a time for us to understand what are the new technologies where we can diagnose them early and take care of the disease. The precise diagnosis of many of the diseases still remains a major challenge because of lack of comprehensive data available and accurate diagnostic methods. There have been a lot of advancement, but still this is a major public health challenge today. Now, if you look at the various diseases, what we have, I have on the left-hand side, these are all the vectors: mosquito, aquatic snails, bat flies, fleas, lice, scent flies. Then we have ticks, and we have triatome bugs, CC flies, and even that n number, much more. I've just enlisted the common ones right here. In India, something like the mosquito I mentioned is very famous, and which is a vector which is creating a lot of nuisance. We have chikungunya, we have dengue. We have, of course, of late, we have seen some examples of Zika here and there. Filariasis is very common. Then Japanese encephalitis. We have some pockets, schistosomiasis in India. We have typhus. Lice is something which is coming up. Scrub typhus is something which is really creating a problem in many of the places. Then various, you can say, the rickettsial disorders by ticks, also relapsing fever, are also coming up. And seen in many hospital settings now, and probably it goes underdiagnosed. Then, of course, so I think as we, we see the many vectors, and every time we really don't know, they come out with something new and we miss out. So it's be careful about the diagnostics. Pathologists have to be very careful and guide our clinical friends. Any of the symptoms, any of the things we have, these are the tests we can really offer, we can work on. Now, the coming down to the lab, specifically the lab diagnosis part. Now, in the vector-borne diseases, in general, lab diagnosis can be divided into two categories. One is a direct method. When you see a microscope, you see a parasite right up there, or maybe a culture, you grow and you have identified the organism. Nucleic acid detection, probably we have a kind of, with RNA, DNA, whatever it is, we identify that. And indirect, it's a detection of organism-specific immune response, where we talk about antibody and serology testing. These are basically two methods in broad category lab diagnostics are defined. Now, acute infections are generally caused by direct, because secondary, the antibody generally developed at a little later phase. Acute infections are, you can really see malaria parasite when the fever goes up right under the microscope. That's acute infection, direct tool. Indirect tools are useful for characterization of secondary or convalescence phase, the recovery phase, and probably as the disease becomes chronic. And of course, there have been tools now coming up where we're talking about antigen, which we detect as early as possible, like dengue, an example, NS1 antigen, which is now there, which is in 24 to 48 hours, but antibody IgG, IgM develop only in 4th or 5th day of fever. So the advantage, if you detect a disease in the very first day, or the very first hour, or very first initial days, I think treatment and complications are, can be taken care of. I think, these are the various platforms for diagnosis of vector-borne pathogens. Now, we have conventional techniques like microscopy. Simple, every lab you'll find a microscope. It's there. I think conventionally we have been using it for malaria parasites and various other things, even filaria we are talking about. Electron microscopy, in some settings we have cell culture, xenodiagnosis. Then we have serological based assays, which is for ELISA, immunofluorescence assays, and immunoblotting. Then we also have today nucleic acid based assays, which is like PCR, LAMP, which is now coming up as a low cost method for nucleic based assays. Fish fluorescence in situ hybridization, which was really used for oncology and various other things, now being used for tuberculosis and even some many infectious diseases. Wire-guided droplet manipulation. NGS is also playing a very important role to identify. I'll probably, as I move forward, I'll talk about each of them, what is the advantage and what are the limitations. Multiplex assays, mass spectrometry-based assays, chip-based or cartridge-based technologies and point-of-care diagnosis, and metagenomics and metabolomics. These are, I think, the various platforms today we can use for various technologies we can use for diagnosis of vector-borne diseases. Now, if you look at, I just say first and foremost thing, the microscope, the commonest thing. Without microscope, there is no pathologist. But that's something which is like we're talking about. But there are today microscope has really become many of times, especially in histopathology, like a PAT scope. where there's no IPs. Probably you have virtual scanners, images are uploaded, and you can see on your screen wherever they are. But that is still, of course, we have a long way to go when every microscope converts it into a screen, and probably we can see that. But the microscope will definitely remain the used methodology, the tool for our pathologists, as probably forever. Now, it's a well-established, low-cost direct method for identification of VBD pathogens. Still the method of choice of blood parasites like Plasmodium or Babesia. Sensitivity is much lower than the molecular diagnosis. Sample preparation can be time-consuming and labor-intensive. This is the disadvantage we have. And there is a the parasitemia or probably infectious numbers are much lesser. It'll be time-consuming, and because you may miss out many of the diagnoses. Actually, method is subjective because that's an individual who looks into it. So, especially in cases where differentiation of similar appearing organisms is required, and if you have a similar looking organism, probably the individual may not be able to identify. You require very significant expertise into it and skill into it. Now, despite these limitations, microscopy represents a useful initial test for the patient with general signs of infection without diagnostic hallmarks, especially in the endemic area, because people actually by seeing, microscope, they can easily identify. There are the malaria screening experts probably in the public health system. Their eyes are so well trained. They just look at those, stay in the slide, look at the microscope. But many of the best of the trained people probably miss out that. I think, so in endemic areas, it still is one of the most sought after tool is the microscopic diagnosis. Then moving on to is another area when you talk about microscopy, software electron microscopy. This electron microscope is still in the forefront of clinical diagnosis of viral and rickettsial diseases. That's where its application is. It's being used out there. In the diagnostic setting today, it's particularly valuable in the surveillance of emerging diseases and potential bioterrorism. Now, diagnostic EM has two advantages basically over ELISA and nucleic acid amplification tests. Now, what are the two advantages? Because it's EM, what we do is you have preparation, you stain, and once you stain and you identify. So after a simple and fast negative stain, EM enables fast morphological identification and differential diagnosis of infection agents contained in the specimen without need for a special concentration or more reagent. Otherwise, you have to do a stain again and again, the first step, second step, third. EM can actually, you can obviate all that. You want stain and you can identify something pretty fast. But nevertheless, it has a disadvantage. It cannot be. It's an infrastructure issue. It's an expensive kind of a thing. It's not available across at almost very, very top leading institutions. Otherwise, it's not there in the public forum. So it's really used only for research purposes. And maybe sometime we have some kind of an endemic or epidemic happening in zone. Samples are brought to central place and reported. So it's really not a public health tool as of now, which is used in the routine diagnostics. Now, cell culture, in fact, that's where the cell culture is another gold standard diagnostic method been used for traditionally, conventionally for it. But it's a time consuming. Culture takes to grow. Isolation of pathology is not always successful because if the quantification is less, maybe sometimes error, temperature, media, whatever it is, some fall, you may not even able to harvest the right kind of a pathogen. Now, cultivation is slow growing. It even, always, it takes many of the organisms very, very slowly they grow. It takes a lot of time to, identify. And by the time you require immediate treatment, you require immediate diagnosis, but may not be. You get report after 2 weeks or 3 weeks. What is the point there? Then our cultivation methods have improved over considerably over the past several decades with advancement in scope and various media, various things have come up. So this cultivation is actually becoming better. Cell cultures are definitely becoming better day by day. Then we have so today, in fact, culture is definitely used only for harvesting and very, very limited use in the current setting. Now, xenodiagnosis is just probably like it was a practice which has been used in the past, and it's a feeding of natural arthropod vector on a patient to have direct evidence of infection. But it is more of a now can be used as a complementary tool to verify various molecular advanced methods. But there is an important need to know the scientists to this. They should be aware of the, and they should really be at least learn and be an expert to understand, because it can be a very, very important use as a complementary tool whenever the molecular diagnostic methods fail. Then we have serological based assays. That a lot of focus is happening on serological based assays. Then what are these? Serological tests are employed in screening and surveillance. Today, you can say everywhere we have card-based tests. We can, we can have, these antigen antibody reaction kind of a thing, antigen antibody testing. These are all serology ELISA-based investigation and point of care testing. They are definitely used for like malaria antigen. What we have, it's all been used at all level. And COVID antibodies are already been of card-based testing. So many of these scrub typhus, we have a card-based test. Now we have wide diagnostic time window, but serological based, as antibodies pathogen may persist for months or even years. So this makes these assays valuable to investigate past exposure to vector-borne pathogen. That's another advantage. Like dengue, we see IgG and IgM. Many a time patients are recovered, but sometimes patients come back and we find IgG is positive. That means some patient was exposed to dengue in past, although has recovered. So this is one of the advantages we have with the when you have the serological based test. Now, another advantage, easy and simple collection, easy sample, drop of blood sometime, just a mix, concentrate, and just apply. Mainly blood, you don't really require even a proper phlebotomy, even a finger prick is good enough. Then ability to detect current infection by seroconversion, that's also biggest advantage. The poor sensitivity in the early stage of infection, I think that's another area, because they may not be able to, because antibody may not have developed the initial stages. It takes 3 days, 4 days, 1 day, whatever the time. The potential cross reactivity can also happen, because between genera of viral, bacterial, pathogen, there could be some cross reactivity. So you may get a false positive or false negative test, and they may not be, the right kind of a diagnosis. Now, but yes, with the advancement that is happening to improve the diagnostic specificity, various recombinant or purified antigens are being really used, and now the newer the serological based assays, I think they're becoming more specific, more sensitive, and more helpful. Now, the serological based continue on these assays. We have ELISA, IFA, and immunoblotting are the most widely used assays. And results of such assays must be interpreted with caution, since a positive test could be associated with past infection and unrelated to the current clinical sign. I think that's an area one really need to look into it, because somebody can test positive, may not be. This is more seen, say, many a time in TB ELISA and other tuberculosis. The patient doesn't have an active tuberculosis, does not need a treatment. So clinically, the clinician and the pathologist should be aware of the interpretation and what to tell the patient and what to tell the clinician and how to handle as they move forward. Then advantage of these assays, besides conventional single pathogen assays, some tests detect multiple the vector-borne disorder. This is something which is we can do today, and we can identify many of those in a single the test. Probably multiple pathogens can be identified. That's advancement is happening as we're going forward. Slide, we move on. Yeah. Now we have a nucleate-based assays. This is a molecular diagnostics I have mentioned to start with. This is an era of molecular diagnostics. We have the molecular diagnostics allow a fast detection of DNA, of RNA of a pathogen, and even the small amounts and some microscopic infection. So it becomes definitely a better tool as compared to conventional tools. Now the PCR, this is the commonly used techniques. Then today we have standardized protocols and highly specific and highly sensitive. The PCR is becoming a better day by day. Then optimized techniques of PCR have been established. We have various, nested PCR, touchdown PCR, multiplex PCR, RT-PCR. Now we have very, very quantitative PCRs. I think these are all not technologies that protocols have been established. And I think going forward, I really feel that we should be aware of the application of PCR and utilize these platforms for identification and the correct identification of various vector-borne pathogens. We have a limit, but this has its own limitation also sometimes, because what kind of a sample should be used, whether it's like TB PCR. The problem was people were using bloods as a sample for TB, which is really not the right sample. The storage and the transportation, the right temperature. I think this is a little limitation, but I'm sure as we move forward, as the new technologies are developing, these all logistic issues have been taken care of. Now, false positive PCR results are a problem because primers may non-specifically bind to DNA of vertebrate hosts and other pathogens also. So, but this can be identified by sequencing and amplification, and this can correct. So, in the PCR followed by sequencing, probably whenever we have a false positive results. But again, it's sequencing is costly and requires an additional step. The positive results in molecular diagnostic do not necessarily mean that acute infection is present at the time of sampling. That's we should be very well aware. Asymptomatic cases might be diagnosed. Post-treated samples can give false positive results even months after treatment due to circulation of nucleic acids of pathogen. So every such test has to be really correlated well with the clinical findings and other findings, and of course in the wake of past history. And I think clinicians have to take a judicious call based on their the clinical judgment. Cellular technology for a molecular efficiency now, which is evolving, fluorescence in situ hybridization is based on a specific nucleic acid hybridization indicate the presence of targeted nucleic acid of the pathogen in the sample. So FISH is now, I think, one evolving technology which is being used for, it has been used in the past also, but I think it is now more available and can be used. We have a fluorescent material can be tagged and becoming more and more automated now in fact. And then it can probably give special information and distribution of organism, and contrary to the PCR-based reaction where it could be positive, negative. Here we can have the distribution also. What is the sparsity or what kind of numbers we have, and they probably target more of a ribosable RNAs, and it can be multiplexed by doing different fluorescent molecules. Probably by FISH at one point of time we can identify multiple pathogens. Also, the new technologies are now capable of doing this. It gives a more accurate view of microbiological community and can be applied in a different environment. Probably surveillance is something we can have, and we can identify more of epidemic studies, which is definitely the need to understand the hotspots. Then limitation is autofluorescence of some proteins, which can introduce false positive or ability of probes to penetrate into the cells, because that could be one of the limitations, because many of the proteins which are there in these the pathogens, they can probably have or create some kind of the interaction and cross reaction, and maybe they not allow that fluorescent dye to penetrate inside the cells, and we probably will end up with the false results. The next is the NGS. Of course, everybody talks about NGS sequencing, NGS and NGS, and this has now been and one of the fast and reliable DNA sequencing without a prior knowledge of targeted genome. It's actually, it's gives you the entire genomic sequence. Whatever is there inside, entire whole body genome can be identified. So is it possible to rapidly sequence DNA directly from the vector? This is something what we have today without the bias introduced by standard identification methods. So that's NGS is playing a very, very important role. You can identify the entire sequence out there. This is what all is happening. Now, identification of different levels from one family of parasites, probably sometimes we miss out. So various strains of those, because that means it's becoming more personalized and more precision based, because one family may be highly infective, one strain may be highly infective, other strain may not be that infective. And that's what, even example right here is the COVID. We have various variants coming up, and some variant was highly effective, some is more severity, some more mortality, and I think that's something NGS can be a very, very big use as we go forward. It can detect unknown parasites sometimes, which is we don't know about it. I think NGS can help. Moreover, by sequencing messenger RNA, NGS can provide a quantitative and qualitative evolution of, again, the microbial community altogether. Its advantage is fast, it's reliable, it can circumvent culture, might take 3 weeks, but today NGS, you can actually have results in 48 hours to 72 hours. And they are now actually it's a variable tool to monitor pathogens and ticks in animals even. And so we can know the potential if we start surveillance the animals, what kind of organisms they're carrying. Probably we can take precautions and develop some kind of a preventive measures as we move forward. And but disadvantage, everything has its plus and minus. It's like equipment is too expensive for many labs. Biotech companies are continuous, but many biotech companies. In fact, at some point of time, I still remember that we had about 5 years back, we had probably just about 5 or 10 NGS in 5 to 7 NGS in India. Today, we have more than probably 200 NGOs in India, but now, and they are not only the research setting, but in the bigger hospitals, bigger labs, and NGOs. And because the availability, cheaper, faster reports, and the new companies are now working really on a better technology, faster and easier NGS, the requirement they're working on. It may not require air conditioning even, but today companies are developing fast. NGS is definitely going to be one important tool for diagnosis of these vector-borne pathogens. Multiplex assays, again, a nucleic acid kind of a thing. The various, compared with the traditional ELISA and PCR, multiplex assays have a number of advantages. We can require a less sample volume, efficient in terms of time and cost, to ability to evaluate the levels of given analyte and perform repeated measures probably, and in the same experiment settings. Multiple pathogens can be detected in the same and may cause, which can probably, be cross-reacting, have a competition with the PCR. But in this, I think new technologies have come by multiplexing, we can identify and have better results. Mass spectrometry based assays, I think that's another area which is coming up very, very fast. The mass spectrometry has recently emerged a diagnostic tool in clinical laboratories. From the one sample, you can actually even use, especially for the biochemical assays. It's been used for drug assays. It's been used for, say, vitamin assays. Probably one column can do mass spectrometry, use pathogen protein profiling. Various proteins can be identified, and which probably can have identify and pinpoint the kind of organisms one is probably harvesting and harboring inside. Now, for the detection, this has been used for malaria parasite, for detection of diagnosis of malaria parasites, both in vitro and vivo. It has been used now as a routine, rapid and high throughput MS has been developed. And there are in some areas, when you especially do surveillance areas and endemic zones, it is really being is helpful. I'm sure sooner or later, the bigger labs or bigger centers or bigger hospitals, you'll see the utility as we come into the right clinical practice. Chip-based technologies and point-of-care diagnosis, I think this is the need today. I think everybody wants a report right now, and as early as possible. And they really, nobody wants to wait. And when it's very important too, because somebody got a fever, you don't wait for 3 days, because this is the era of antimicrobial resistance, actually. You can't wait, give symptomatic and give one antibiotic or wait something. If you have a diagnosis right up front, within 2 hours, 3 hours, 4 hours, you can take care of that. So chip-based technologies, they have, or POCs, the advanced disposable, pick up sample, do it fast. It's a cost effective, it can be taken. Ease of use, you don't require many of the skilled people right here. Portability, you can pick up your the cartridge, whatever the equipment from one place to another, pick up in your car, and it's really happening. People are actually going from one location, portable labs, mobile labs, or doctor clinic lab. Doctor carries in a box, like, their car, they have a small freezer and they can carry the kits and they go from one clinic to another clinic. So this is the POC diagnostic is able to analyze small volumes actually, and now they fit various body fluids also somewhere, not only the blood sample, maybe urine sample, maybe saliva sample. Systems can be now automated. They're making more and more miniaturized, And enormous advantage can be there, with hardly any protocol, probably just have 1 or 2 steps, and it works very well. They're integrated, they have an inbuilt quality control. They're integrated with the information technology entire LIS. Probably sitting here, a pathologist, I can see if my technician is doing the right method or not. And probably we can control and deliver the report on the spot, and because without much of a hassle. So it even nowadays we have certain the chips which probably with the nanotechnology and the biosciences, where we can actually detect many pathogen species in one sample itself, which is also because there's a co-infection is comorbidity, because malaria can cause 3 different dengue, and probably the malaria can be together. So probably this is what people are talking about. Can dengue or COVID can be together? Because I think the technologies are there and they can work out well. And future is going to be full of such things, I feel, because as the way the healthcare is getting more complicated and people are traveling globally, right, left, and center. Earlier it was yellow fever was here, Zika was here, Ebola was there, malaria was here, but now world has become one. Metagenomics and metabolomics. Metagenomics is applied again. This is something, various metabolites which has come out, I think, which is again, which can be identified, and we can work on a lot of things happening into all this metabolic identification, and probably coming to helping the diagnosis. But now that's where the whole technology platforms are. Now the gold standard is the time for revising. Now that's something what we talk about. Our gold standard was, we have worked on a various method like microscopy, culture, serological test, and there is various in microscopy, there's expertise is required, cell culture takes a lot of time, serological tests, cross reactions can happen, but molecular assays have become widely available and used for malaria and leishmaniasis. Then there's there's going to be paradigm shift. Probably, yes, they're helping in viability of organism is no longer necessary. Assays can take hours instead of days. That has become smaller and smaller. I think again, PCR in fact, rather for that matter, tuberculosis, a lot we can see that we have various the TrueNAC or Gene Expert, where the reports actually can be given as early as possible. But this one thing was happened is we have identified probably at one point of time, one was thinking, oh, this disease percentage was incidence was much lesser, but because of the finer detection, better detection, we have been able to identify the prevalence of some diseases probably gone up, and that's because of the better diagnosis and better technologies which are available today. The newer application LAMP, which is again one of the technologies where we don't even require a thermocycler. You can actually utilize it, and it's probably going to be good use, put to use. LAMP is being today used for COVID. It's used for tuberculosis. I think sooner or later it will be used for many other things as well. Now, chip-based cartridge hybrid diagnostic technologies can deliver major breakthrough, and they have own very big advantage: disposability, cost-effective, portability. I've already mentioned in the past. So then undoubtedly a potential turning point in the molecular diagnostic. This is where we are heading for. The new trends are now from what we started on a microscope. We really can see on the spot, finger prick, probably wherever you are, and you can probably see more precise and more finer diagnosis. And the new technologies are going very, very fast and getting cheaper, affordable, accessible, so that the remotest person, probably the very purpose of Indian healthcare is to address and give the treatment to the last man out in the post, because our 30–40% of people are still into tier 3, tier 4 cities where facilities are not up to the mark. But the challenge here is that everything has its own plus and minus challenge. We should understand that some challenges. Most of the molecular tests today are based on non-standardized laboratory methods, but I think they're getting standardized, and soon we are up there. Quality is still the challenge in the PCR, but as we get more automated, much better. Probably the kits are become cheaper and cheaper. Reagents get better and better. Probably people will not use a lab developed their own reagents, and they can utilize whatever the standard reagent, not dilute them, and probably work in a better way. Testing systems are often complex and expensive. They require specific temperature, skilled manpower. All this is now automation is getting its away. Now we probably can have a instrument which can carry in your car and probably do some kind of a testing right there without worrying about extremes of temperature. So as a result, the use of lab, but the challenge is currently because of this, the limit today, the use is limited to central referral lab and specialized research facility. But soon you would say more path cafes coming up, where probably you can walk in and probably in the small cities, give your blood sample within 15, 20 minutes, you have a blood report and you can walk out. Meanwhile, you have a coffee ready with you. But now these some questions arise out of it. Lastly, before we sum up here, can these tests have enough sensitivity and reproducibility to replace the traditional method? That's the question. A lot of research is being done. A lot of research is happening. I think yes, probably sooner or later, maybe not. I don't think it's a question of decades now. It's a question of maybe a couple of years, and something applications already happened. They are started replacing and getting more sensitive, and traditional methods are being replaced. Then what kind of changes sample collection logistics are necessary to conduct? Yes, today better, when you have a better kind of sample, you may not require blood sample. Probably you can require a saliva sample, you can have a spit sample, which can be transported. Even a paper technology, probably we have just a drop of blood, you just put it in an envelope, ship it everywhere, it doesn't require any temperature. You can get this is more technologies. This is all to be a change, definitely. Now, lab personals, or even veterinary, because this is something with animal they work on, these specific technologies, yes, I think sooner or later, this is already happening. This is still, but these are the questions what I'm saying, they're going to be need to be answered and will be answered as we move forward. Sooner or later, I think we will overcome all these. Now, the decrease another time is what the additional cost. That's something the healthcare providers will talk about it, because cost may be high. But I think I like to say one important point here. Cost is something which is you relate to, life, actually speaking, because it's not like, because it's something which is, if you diagnose something early, if you prevent something, complication, because if your patient comes, the complication, they spend much, much more. We have a 5 or 10 days stay in the hospital, mortality is more, expenses more. But if you identify the disease the very first day, give an anti-malaria or anti-scrub or anti-rickettsial medicine right on the day one, instead of prolonging for 7 days, overall expense may be lesser. So I think that's where I think we need to really change our mindset here. Like, very important to have your assays, diagnosis as early as possible, and anything which is going to be important, I think going to be little cost, but overall project cost will substantially reduce if you take care of that. So it is this is a very, very question, is it time to replace old-fashioned techniques with modern and high throughput ones? I think yes, but I think many of you probably will say it's going to take time, may not agree, but I think yes, I think sooner or later, 5 years from now, probably we have another tide event, and we'll be able to say, yes, we have done it, and we agree with that. I definitely agree with that. Over the past decades, just example, what we've seen is, the genomics and transcriptomics. So omics is one area which is now we're talking about omics. And genomic era, the first vector genome to be sequenced is Anopheles gambia genome. This has already been identified now. I think the huge amount of omic data which we have is bioinformatics is coming up. So I think this is the genomic data, the omics, the various NGS sequences, and various surveillance methodology. All this put together will be able to give us a very informative tool. Which area, if I walk in, I have to take a preventive measures, because there is an eastern area where cerebral malaria occurs. Somewhere we have Bihar, we have something, UP, Western UP, Eastern UP, we have encephalitis. So I think that's all put a bioinformatic tool put together, hotspots identified, and once you go there, you can order preventive measures. So instead of wasting for a TB test, probably in some area like hotspot, you straight away go for the dengue test, and you have the answer with you. So I think this is something which is going to be important use of technology. And innovative technologies are being the more incorporated in the workflow. Diagnosis will slowly step aside, and the traditional diagnosis step aside and serve as a supplement or a confirmatory to methodology. The new technologies are definitely going to be here. Now, remember, change will create new winners and new losers in the marketplace. Change is both the same, but the change will also create new opportunities for R&D, for providers, the devices providers, and even, of course, the diagnostics people. The diagnostic providers need to be alert for new technologies. Events will create a change and position the lab organization to benefit from these opportunities. We should be ready for it. That's it. Rapid change has become defining future of pathology. That's how it started with, and that's what it ended with. We need to work on it, and probably I've spoken almost 45 minutes non-stop. Thank you so much.
Thank you, sir. Thanks a lot, Dr. Gaur, for your information and your elaboration about a lot of things, which even I not knew, like molecular diagnosis, microscopy, cell culture. Yeah, there is a word हमको चलना होगा. So pathologists are going with current situation and they are going for futuristic way also. Sir, one question is there which come in my mind. If you permit, may I ask you?
Yes, please.
So the question is, we have watches, we have few instruments in our hand, like even in mobile. Are they are reliable for tracking our blood pressure, sugar, like these things? Are they are reliable?
Well, I'll say, if you look at the COVID scenario, every house has got a clinic. We have a table
Yeah.
next to our bed, which has, where you can have wearable devices or oxygen saturation. I think a lot of validation is required in my mind. They're really, it's not like this is because we cannot stand alone. No, may not be. That's not because I'll give because I'll give you an example here because I was somewhere in the Western world, somebody is developing a smart toilet. Now, it's something like, once you get up in the morning and you go to the restroom, and once you come out, suddenly you find an ambulance at your doorstep because whatever you have, in the done the yours, the spit or saliva or urine is indicated, and alarm has been created that you already landing up into some hypertensive stroke or you have high sugar has gone up. So I think this is actual reality, to be very frank. But I think it's very important for all of us to know that. I think these are all validation, evolving phase. Everything has to be seen in a clinical setting. You cannot set in all alone. Somebody is not diabetic, somebody is not hypertensive, and your watch or something shows, oh, you got a high sugar. It is probably wrong. Battery is wrong. Something is grossly wrong. That's why the glucometer test also, if you look at this point of view, people do glucometry testing, become very, very accurate now. Glucometers have come, strips have. But they still say, okay, every 2 months or 3 months, if I'm diabetic, let me get a test done from the pathology lab. Let me verify it. Let me validate it. There are better controls into it. I think both have to have their own space and have to be very careful and integrated and work well. Standalone may not be, but yes, I think if you're alert, if you're a little counseled well, and it can help you.
Thank you, sir. Any question from your side, Arjun sir?
Dr. Gaur, at the very outset, thank you so much. That was not just one presentation. Let me put it that way. It wasn't one presentation. It was a whole a new tide, and it was like a tsunami of a presentation, if I may say so, because you covered so many subjects within the span of the last 55 minutes, right? That sometimes even for me, keeping track of them was proving rather challenging, right? I did have a few questions, the points that I wanted to have, a little more clarity on, because given your depth of understanding of the field that we're talking about, you talked of a lot of movement, especially in the pandemic, where a lot of testing has moved from the hospital to the home. In fact, even the COVID test, we moved from having to go to the hospital to having the lab come home to us. And the next stage of this evolutionary process is naturally having a lot more of the tests, non-invasive tests at least, happening at the home front. But unless they're integrated with a healthcare provider, unless you're integrated with a medical practitioner, those will not prove as useful, because otherwise we'll be relying only on Google and WhatsApp University to get our results, right? So what are the challenges you face, you believe that we need to overcome over the next, let's say, 5 years, maybe 10 years, to cross this barrier, because we are at a tipping point right now. So how do we cross this barrier? What do you think are the challenges we face in this direction?
See, one thing is very, very relevant today. I think that has been a standard conventional teaching that remain forever. No test or diagnostics standalone should be taken. No. I think it has to be first read in an entire clinical setting, number one. So whatever, I think, the home care is definitely going up. Home testing is going up. Near patient testing is more. And you'll probably see more of a point of care testing, more of a different type of sample testing. But this is area we need to be very careful about it. We cannot read those tests. Machines will be more accurate, more better, much better, but they have to be read in along with the clinician's judgment. I think the tool is it's not like a free tool available to anybody. Use it and do what you want. No, you might hurt yourself. I think it has to be keep your clinical clinician alert. Probably that is what I mentioned about integrated diagnostic system. You really need to be online, very well connected with the clinician and your doctors, because that is what going to work. Otherwise, standalone people are walking, and like many a time I have actually seen many a time during the COVID people coming. Oh, they're getting the COVID testing done every day. They just came out tomorrow. Yesterday I went there. Oh, I'm going to cough. Do it again. I mean, they're panicking kind of a thing, because what is the point? Because somebody told me cough will have this, we'll have this, you'll have this. So even like, slightest, I just went out and drive, I opened my window, let me have this, because somebody was standing on the roadside. So that is not the right thing to do, to be very frank. And I think what we really need to is forget about Googleization, to be very frank here, because that's what is creating problem. Google cannot be your first doctor. First doctor will remain first doctor. You will actually have to have Google as a third or fourth, you have to supplement rather. It's augment your intelligence. You cannot replace the intelligence. I think this is something awareness. Of course, when it comes to devices and technologies, they have to be, various validated and integrated together with various labs, point of care testing, your clinician, everything has to be aligned. And probably whenever you find the graph going out here and there, just question mark. Don't get panicked by it. This is what I really have to say at this time.
Thank you, Doctor. Thank you very much. Another question, a follow up actually, because RT-PCR today has become what you call, it's like the Bisleri. We think of Bisleri, you think of bottled water, you think of Bisleri. Same thing, you think of COVID testing, you think of RT-PCR. But they don't know that there are multiple types of PCRs available. What is the actual effect that goes into a PCR? And with the advent of the pandemic, PCRs and molecular diagnostics, especially in India at least, have seen a big jump. There's been a quantum jump in the direction, as you said in your presentation also, there's been a quantum jump in the direction of molecular diagnostics taking over a lot of tests. Now, as we wind down, I'm not saying we are finished with COVID. I'm not saying it's over. I'm just saying that as we wind down from that testing, that initial high that we had in the first two waves, where all do you think, what all tests do you think, where all do you think there's a future for PCR? Because the number of people who adopted PCR machines in India today is a very high number compared to 2019, December 31st, right? Today there's a vast sea change. So I look at this as one paradigm shift that has already happened. Now, what do we do to keep that paradigm shift going in terms of what do manufacturers need to do to make sure that they reach that the machines are utilized effectively? What new tests do you see we can move to the PCR, to the molecular diagnostics sector?
Rightly agreed, because I think now we have about 3,000 plus labs doing RT-PCR, and which was before COVID, we just had probably none in the private sector. So everybody is equipped with the RT-PCR. What do they do? And there's a question being asked, even my lab people, we have 5 instruments and extractors. What do we do now? But I think application, that is one part. I think we can apply, because you have understood the importance of RT-PCR. You're getting a finer report, better report. Now, various infections probably. Today, like we have a rapid septicemia cases, respiratory infection, GI tract infection. We can have, especially in a pediatric infection kind of a thing, where people are like to know whether, whether it's a viral infection or bacterial infection. That's something they like to know that before starting an antibiotic. So I think, even like, so why not the dengue PCR? Why not the chikungunya PCR? I think that's more this thing. Malaria, I've already mentioned, people are talking about something, malaria even also. So I think application of this has to be now utilized. I think we need to apply this and getting more specific and more sensitive technologies. But let us not go where the TB PCR is gone. because I think that is where I need to be very cautious, a word of cautious here, because people's applied TB PCR technologies, any possible sample, which was there, things went bad. And even blood sample for a TB PCR, reports were not right. And then the medical community start losing faith in that technology. I think so. There is an application definitely in the infectious disease, because infectious disease have come back. As we mentioned, we already have the vector borne diseases. This also now coming back. We have today talking about Zika coming up here, Ebola coming up, bird flu coming up, avian flu. I think let's get ready with that. We have a tool in our hand. We have machines in our hand. We have skilled manpower in our hand now. So there's no, like, people are not, like, technicians are very well skilled to handle these samples. We have biosafety cabinets all together. So I think this piece, and of course, another area of PCR is been oncology, which is, I think, it's been there for a while and now established. Probably you can go for oncology and infectious disease, oncology, various type of samples. And these are the three areas I think I feel going forward, people should look into it.
We do have another question, Dr. Saab, from Dr. Vardini. Apart from testing HIV using RT-PCR, what should be the next highest infectious disease routinely tested during PCR? I think you already shed some light on this with respect to dengue, chikungunya, and like you said,
hepatitis. We have hepatitis. Hepatitis is a big way. Hepatitis B, hepatitis C, HIV, herpes simplex, CMV. I think there's something which is HSV is also being used, especially meningitis cases. Hepatitis is another big area,
Right. So, well, I could have a lot of questions for you, sir. In fact, but I guess we are on a time limit here. We have some time constraints, Ms. Jain. So, thank you, Dr. Gaur. That was very informative. In fact, we should have a full day scheduled for you next time for this kind of session because of the level of inputs you provided. Ms. Jain, over to you.
Thank you so much.
Thank you, sir. Thank you, Gaur, sir. It was very insightful. Thank you, sir. Now we are moving towards Incredible Bharat. So, Doctor, there are many doctors in front of me. So, once one in World Scientist Meet, somebody asked a question. That question was, what changes from liquid to solid at a very high temperature? As we know, at a very high temperature, the liquid cannot be converted to solid, right? So there were USA scientists said science does not support it. Somebody was from France. He said it's not a good question. Japan said we did not know. Russia said no, such things does not exist. But can you think what a Indian scientist said? His answer was, it's idli. Idli is a liquid, can be converted into form of solid. So, okay, fine. With a smile on your face, we will take a 5 minutes break.
Ma'am, just 1 minute, Ms. Jain. Before we leave, let us not forget our little duty that we must do, right? Dr. Gaur, we would have love to have you in person right now and present this certificate in person. But for now, please allow us to present a little digital certificate of appreciation for the time and effort, sir, that you've expended coming here and spending it with us, sir. We look forward to continued linkage, and I will personally be reaching out to you sometime next week and catching up with you, because I want some more input from you, sir. This was a very interesting discussion. We are having to actually cut it short today. Thank you, Dr. Gaur. Thank you, sir.
A pleasure. Thanks.
We'll have a short tea break, as Ms. Jain said, and before we go into the tea break, I would like to inform everyone that we have a CME scheduled for tomorrow, and it is approved by the Medical Council of India, and all medical practitioners who attend this particular CME will get 1.5 hours CME credit, right? So this is being done at under the aegis of Milap and Dr. Neera Jain. We are very happy to bring this to you on the Tide 2021 portal. And the link is available in the chat screen. You are most welcome to register for the CME. Ma'am, Ms. Jain, what time do we reconvene with Dr. Padma Srikanth?
After 5 minutes only.
Right. So let's give it, it's 3:22. I think let's give everybody a 8-minute break. So we join back at 3:30 and start the conference again.
Sure. After 8 minutes, we are going to back, so we will wait for you. Thank you.
Thank you, everybody. Dr. Srikanth, we can see the presentation, ma'am. Vidiji, we still have 2 minutes. So I think Dr. Saab is ready. We got a minute now. So, if you want to start, you can start, and then at 3:30 we can start with the show.
Hi, ma'am. Hi, Shrikant, ma'am. How are you?
Hi, I'm good. Thank you. How are you? Good to see you.
We all are fantastic because you are there. We know it.
Very kind of you.
It was a nice session yesterday. I want to know only one thing. Being a lady, how could you manage your job work, your diagnostic work, and your life? It's a very common question. During this time, I want to ask.
Yeah. Actually, I think these situations call for multitasking, and I think women are very good at that. So, and we are also, I think, able to deal with uncertainties and unexpected situations better. No, because as you when you deal with children, you learn to expect the unexpected. Because you get kind of prepared, mentally tuned to that. Okay, this is the worst case scenario. So when you're dealing with those worst case scenarios, then mentally you're prepared. And I think after that, it's just to convert it into the best case scenario. See, world over, we saw that women were able to, women leaders in governments were doing extremely well in certain countries. They were coping very well with COVID-19.
So I think we should give applause to all the women who are in the medical field, medical industry. Thank you all. Shall we start, Arjun sir?
Yes, ma'am, please. Dr. Srikanth, a very good afternoon and welcome to TIDE 2021. We are extremely looking forward to this presentation because this is one subject, especially dengue, which is very close to our hearts at J.Mitra.
Yeah.
Close to our hearts, really.
Yeah. Over to you, ma'am. Over to you. All yours.
Thank you. Good afternoon to all, and thank you very much to the organizers for this kind invitation. I indeed consider it a privilege to give this talk on dengue disease dynamics and dengue diagnostics. And I do know that J.Mitra have been leaders, not just in the forefront in HIV, but also in dengue. Okay, so I need to move to the next slide. I think there's some problem in that.
You can just hit the right button if you want. I think the right arrow should work.
It's not working. Has it been enabled for me? Yeah.
Yes, ma'am. It's enabled. That's why your screen is shared.
Correct.
Just hit the enter button or hit the right arrow button.
Doesn't seem. It's that I had a big file, so I have not shared it.
Or you can hit escape and then press. Are you on a Windows laptop, ma'am?
Yeah.
Just hit the escape button.
It does look like it's
got hung.
Yeah. I'll do the stop share and see. 1 minute.
Yes, ma'am.
Sorry.
Okay, so then I'd like to give introduction of doctor in front of Shrikant ma'am. So seriously, a big salute to the knowledge of Dr. Shrikant. For the second session, we have Padma Shrikant ma'am from Sri Ramchandra Medical College and Research Institute, Chennai. Dengue continues to play havoc across the country every year. Dr. Shrikant will be speaking on the dynamics of dengue and Dengue Diagnostics, and today we are going with a very good, knowledgeful event because it is affecting our daily, day-to-day basis life. So it's all yours. I think your screen is working on, ma'am.
Yes, yes. Thank you so much. A
Stage is yours,
temporary
ma'am.
glitch. Yeah.
Yeah, ma'am, please.
So the outline of this presentation is that first we look at dengue as a febrile undifferentiated fever. That is, as the patient walks in from the clinician's perspective, the burden of the disease, about dengue virus and the pathogenesis, the dengue disease dynamics and the dengue diagnostics, and actually the presence of co-infections. Just because we've got a diagnosis of dengue and the clinician treats that, and yet the patient is not getting better, we have to watch out for co-infections. And lastly, a little bit about biomarkers and whether that could assist, especially when there are gray zones in the disease dynamics, when diagnostics don't seem to help. So most of this presentation is based on some of the work that we've done in our own laboratory, and also based on a PhD, one of my PhD students' work that I'll be sharing. And of course, what is happening in the diagnostic front. So acute undifferentiated febrile illness is when the fever is less than 14 days duration, and there is no organ or system that is typically involved, and the clinician is now in a dilemma. So the common diseases are dengue, malaria, scrub typhus, typhoid, and leptospirosis. And this is a huge burden. And recently, a lot of viruses are emerging and re-emerging as pathogens. And we do know what impact COVID has had over the last almost 2 years. Now, if you look at dengue, in the 1970s, just 9 countries worldwide were reporting dengue. Now it's by 2007, it is reported 128 countries. Now it's way more, at least 200 countries worldwide are reporting. And this is a huge burden. 70% of the burden is actually in Asia. If you look at what is happening in our own country, the National Vector Borne Disease Control Program, we are now hyper-endemic for dengue, and the case fatality rate is actually 2.6%. If you look at the virus, and we are also familiar with the vector, the Aedes aegypti and Aedes albopictus, it's a single-stranded RNA virus belonging to the Flaviviridae family. There are several viruses in this group that accounts for the cross reaction sometimes we encounter during the use of the diagnostics. Now, I'm going to use the WHO case definition, which was put out in 2009, that will allow us to look at the disease dynamics in the context of probable dengue, dengue with warning signs, and severe dengue. This categorization is useful because then we'll know which test to use when, and get a better understanding of the application of the diagnostics test and what are their limitations. So there is also important aspect here that there is a dengue vaccine available. The immunopathogenesis of the disease is quite complex. In that context, I think we can, the experience we have with COVID-19 will certainly help us in looking at the immunopathogenesis here, especially in the context of antibody-dependent enhancement. And there is this molecular mimicry, which is due to certain components of the virus, the NS1, the E, as CPRM, and so on. Now, the reason for the widespread reporting of dengue is because of the international travel and climate change. And like I said, I'm using three aspects here based on the WHO case definition as probable dengue, dengue with warning signs, and severe dengue. Now, the reason why I put this is like we look at the patient walking in as febrile undifferentiated fever. Then we start applying this case definition. There is just a probable fever, and this fever is fever with rash. There'll be body pain. This could be chikungunya. It could be malaria, and there is no system-specific, manifestation. But when it moves to warning signs, there is now fluid accumulation. There is liver enlargement, and a mucosal bleed. So now there is more differentiation. And lastly is the very severe manifestation, just like we see in severe COVID, or where there is now plasma leakage, fluid accumulation, respiratory distress, organ involvement, multi-system failure, and liver enzymes are hugely elevated. So this spectrum of disease is very important to follow. And if you look at this in two ways, one is also what we have just done as WHO case definition, and the other is as the primary infection, acute self-limiting, and secondary infection, which is with non-protective antibodies bind and facilitate the entry to monocytes through the FC receptor. What is this? I'm just going to come to that. And there is a huge release of cytokines that causes hemorrhage, shock, and death. Ebola and HIV do have a similar effect. Just to quickly go back, the virus has 4 serotypes. Even a 5th one has actually been reported, but is not universally accepted. So we have 4 serotypes of the virus, like you're seeing in COVID-19, SARS-CoV-2, so many mutant variants are emerging. Here we are referring to them as serotypes: dengue 1, 2, 3, and 4. 1 and 2 have been most frequently encountered in our country, and are the ones which are usually associated with severe dengue or the dengue hemorrhagic fever. So the primary infection is when the infection occurs with one serotype. Secondary, please, we must remember that the immune response here is such that it's not protective and does not last lifelong. Reinfection with another serotype can result in this antibody enhancement of infection and cause the release of cytokines that results in dengue hemorrhagic fever. What is exactly happening within the cells? This is an uninfected monocyte. When the cell is infected with the virus and we see there is damage, you see that there is vascular permeability increases, there is instability, the vascular instability and shock, and the cells there is cell death. So there is these are the changes happening within the cells, and there's a huge cytokine storm. The cytokine storm was earlier referred to as tsunami, cytokine tsunami, which is a very wonderful terminology to use, because that's the mammoth response that happens that can actually damage organs so severely. Something similar is happening even in COVID-19 in the lungs. Now, this is how, when the first serotype has entered the body, there is stimulation of the memory cells. Okay, these are initially dengue naive T cells, and then you have with another serotype, and then it progresses to this secondary dengue infection that I just referred to. So by the first infection, the memory T cells have been triggered, and during the second infection, different serotype, this will result in lysis of infected cells, and antiviral cytokines are reduced, whereas inflammatory cytokines are increased here. So the choice of test becomes a clinical dilemma, and that is especially challenging in the acute phase of the disease. We need a wide clinical spectrum of disease, demands that there should be a right choice of diagnostic method. And because there can be such a rapid progression to dengue hemorrhagic fever, dengue shock, resulting in death of the patient, it's important that the diagnosis be timely. So here, this is the current scenario. If you look at these two graphs here, I have looked at the NS1, which takes at least at the earliest 3 to 4 days to rise, and goes on, and you can get a positive NS1 way up till 7-10 days. Okay, so this is the period that also coincides with viremia, and there is an antigen antibody level in terms of the IgM that rises and IgG, and there is some role for IgA too. Now, if you look at this, usually in second, we'll just go on to another slide, and I'll show you, and I'll show you here that this is the period when earlier conventional techniques like virus isolation was used, cell cultures were used. Even now, this is used for different purposes. And if you carefully follow the how the progression is, that once the antigen is detected or genome is detected, it's the early phase of the disease. Subsequently, it moves to IgM and IgG. Now, there have been lot of demand for rapid tests for detection of dengue, especially given the spectrum of illness. And when they're looking at the rapid diagnostic test, there is a tendency for false positives, because we just saw that this virus belongs to the flaviviruses, and there are several other viruses in this group, including Zika, and there is Japanese encephalitis, West Nile virus, all of which can technically show some cross reaction. In view of these cross reactions, it is not really advocated to use the rapid diagnostic test, but suggested that we go in for ELISA to confirm the diagnosis of dengue. Otherwise, they may be either over-reporting or under-reporting. We are again seeing that's a limitation more of the rapid diagnostic test per se, because we're seeing that even in COVID-19, where rapid tests are the need of the hour, but they really lack sensitivity, and though they are high on specificity. Then we look at culture methods are actually not used because it's time consuming, and the cell lines that are used are the mosquito cell lines, which is again very tough to maintain. Now, if we look at what then to do when the person is in the acute phase of illness, it would be first probably use an RT-PCR, because it's an RNA virus. And I was part of this, I joined this meeting when I heard the previous talk being given and about what is the scope for real-time PCR after COVID. So definitely these instruments can be used further for determining the viremia in the early phase of illness. There's a limited utilization of actually PCR in India for the diagnosis of infectious diseases. I think this is a great way to approach some of these acute febrile illness, where the report will be given in a very short period and it is evidence-based. So one aspect is the detection of the virus by the RT-PCR. The next is the non-structural protein detection, mostly by ELISA or by the rapid test. And then we go have IgM if it is the primary infection. And we have IgG of the primary infection and IgG of the secondary infection when it is with the second with an other serotype. Now, this is how it happens theoretically, but there is a gap between what happens actually, it should happen as textbook descriptions, and what actually happens in practice. This is what we need to really think about when we are looking at the panel of tests available for dengue detection. For primary infections in persons who have not been infected previously, which is most typical in case of most travelers, the diagnostic sensitivity of NS1 in the febrile phase exceeds 90%, and antigenemia can present for several days after even the resolution of fever. So it doesn't mean that the persistence of antigenemia, that the patient is actually going to be still sick, because most of them tend to recover. Now, the choice of test in primary dengue, therefore, is NS1 and the detection of nucleic acid and IgM test. Whereas when we look at the secondary dengue, NS1 detection really drops. Okay, so IgG is there and IgM is a small window. So you compare these two graphs here. You see in primary dengue, NS1, like we just now said, it's a great test to use in primary dengue. When the patient is acute febrile illness and NS1 is negative, does it rule out dengue? We are still not sure, because then it could still be secondary dengue where there is no NS1. There is possibly no IgM, but there is an IgG. And this IgG could be the past infection IgG, or it could be the secondary infection IgG. So that's important to know. And when the disease etiology could be leptospirosis or typhoid or malaria, that's when it becomes the diagnostic dilemma. Okay, now look at this in the context of acute phase and convalescent phase. So there will be definitely a role for demonstrating a four-fold rise in titer of IgG as from initial onset to subsequently in terms of 2 weeks after collection of the first sample. Now, we've just now captured graphically that if it is secondary dengue, there is a role for antibody detection, and that time the sensitivity of NS1 drops. So there is this anamnestic response, serological response of antibodies, which could also be due to cross reaction. So that makes it a little bit more complex. Now, the serological diagnosis relies on this IgM, which can be as early as 4 days in primary dengue. And it is actually, the evidence of IgM is considered as presumptive diagnosis. If we did have NS1, it is considered as a confirmatory finding. But when you do demonstrate rise in titer 4-fold of IgM in paired sera, then it is confirmatory. Single sample detection is only presumptive diagnosis of IgM. Now, cross reactions and anamnestic response, serological diagnosis of dengue can be confounded if the patient has been recently infected or vaccinated with an antigenically related flavivirus like JE, or like I said, Zika or West Nile. And we don't see yellow fever here, but in Africa, yellow fever would also compound this problem. So secondary dengue, there will be this anamnestic antibody response in which dengue virus reactive immunoglobulins would predominate over the IgM. That is, IgG would predominate. Okay, so this is basically to summarize what all is the disease dynamics. So much of dengue disease is asymptomatic or unreported. Then we have the dengue fever, and the tip of this is dengue hemorrhagic fever, dengue shock syndrome. And we have also seen so far in the context of viremia, NS1, and IgM and IgG. And what now I'm bringing to your attention is that there is microvascular permeability, which we briefly saw in the immunopathogenesis of the disease. That's when the platelet count is of great importance and is being monitored. So in primary dengue, you see the period of viremia is here. There is microvascular permeability, which is happening possibly from -2 of the disease to 5-7 days of this. And there is an immune response, which includes the T cells. Then if we look at secondary dengue, the viremia can actually be of, it's a more bigger bump. And you see that immunoglobulins, which we refer to as IgG previously also there, and the microvascular permeability aspect is not very clear here. Okay, but it is because there are times when without thrombocytopenia also patients have progressed rapidly. So it's not, and not all thrombocytopenia is actually due to dengue. So there are two aspects here to be very clear about. Probable dengue group, when we did this study where we looked at 265 study participants with clinical dengue, thrombocytopenia was seen in a huge number, but not 100%. So probable dengue group, 67% had thrombocytopenia, whereas in warning signs, 89%, and in severe, all of them had it. Okay, so this is it's a hallmark of the severe dengue. Now, there is also a thought that this could be a relative thrombocytopenia, or it can be a dramatic drop to like 20,000. Again, there is a textbook description versus real life experience that needs to be used in the treatment. Now, I'm just also sharing some more data that if you look at the performance of NS1, when the day of illness is less than 5 or greater than 5, okay, and this is according to the characterization as probable dengue warning signs and severe dengue. So here we found that 92 of them did have NS1. So that's really good when the day of illness is less than 5. So it's important that patients present early when they have illness, so that these tests will pick up the disease and enable the differentiation as dengue which is very important in determining treatment and avoiding unnecessary antibiotics. If you look at IgM, less than 5 days, only 12 of them had. And once it's moving up to greater than 5 days, 48 of those had IgM. Combined, again, greater than 5 days, it's increased. Real-time duplex PCR. Now, when I'm just coming further to the role of PCR, there are different PCRs that are being utilized. One is recommended by CDC, and we have actually used a duplex RT-PCR, which is in-house. And this is based on established protocols, which enables serotyping, and this serotyping is in the form of like dengue 1 and 3 and 2 and 4. So when the PCR signals are there, it could mean either it's 2 and 4 or 1 and 3. So that's referred to as duplex PCR. So this is again very useful in early stage of the disease. But remember that most cases of probable dengue are self-limiting and recover. So there the virus is cleared by the immune response. Whereas when it goes on to warning signs, much more virus is there. And that's why we were able to pick up many more patients with RT-PCR, which is a clear indication that there is going to be worsening of the disease. And so step up the fluid replacement and monitor platelets very carefully. Now in severe dengue, all cases were picked up actually by the PCR. There was no antibody response, and NS1 was detected in 3 of them. Of course, in warning signs also, NS1 has performed quite well in terms of the number of cases we were able to detect with that. Now, interestingly, I want to also draw your attention to beyond 5 days also PCR was positive. It is not that they were not, it was completely negative. Now, this is a little more about the PCR I referred to. It's targeting 3-UTR region. And we have used the stock viruses, which we obtained from NIV Pune. The lower limit of detection is 5.2 nanograms per microliter. And we tested 350 samples. And of these, 89 tested positive for dengue. And like I said, there are 2 different probes we use. These are the probes. I said 1 and 3 and 2 and 4. And this actually helps. So it's a single PCR, which actually helps in assisting, not only giving us the diagnosis of dengue, but possibly which serotype it could be. Otherwise, serotyping requires hemagglutination test, which is pretty tedious. Now, these are more details about that. And I just, again, here what I want to highlight is that dengue can be picked up by PCR, and we also need to know that we need to sequence these viruses when we detect them in the clinical sample, just like how important sequencing is for SARS-CoV-2 to determine the variants. When we sequenced the set of samples that we had got, which had tested positive, we found that there was a cross reaction between the 2 probes, and what was previously described was no longer specific to only dengue virus 2, the serotype 2, but was cross reacting with dengue 1, and this was because of evolution of the virus, and especially in a hyper-endemic area, there is a need to design primers and probes that are specific for the circulating strain. And these sequences have been actually deposited in the GenBank database. This is again important because when we are looking at our own addressing and developing kits that are locally relevant or relevant to the geographical regions, we need to use probes, and we need to use primers that are specific for the circulating strains. Now, this was published, and that's what I've shared with you here. And there is some more that we, like I said, we had looked at the CDC set of samples too, and there was, we compared the 2 and we found that our duplex PCR actually performed really well. Now, I'll just skip on to some other aspects in the interest of time. Like, this is to just highlight that PCR is very useful for a prolonged duration of time, but it's most useful 2 to 4 days of illness. Now we have another interesting aspect that there can be co-infections when patients have dengue, and these could be enteric fever, scrub typhus, or leptospirosis. So we need to look for those conditions too, especially when there is a complex clinical presentation or atypical clinical manifestations. Here we have a case, 2 case reports. Both of them had typhoid along with dengue, and there are also reports of staphylococcal infections and pneumococcal infections in patients with dengue. Okay, so this is regarding I have previously mentioned about the rapid test as well as dengue NS1 antigen as a marker of severe clinical disease, which is what makes NS1 a very useful test in early detection of dengue. So the take-home messages is that it's important that we have early rapid real-time diagnosis of dengue, serotyping of the dengue viruses, that the viremia actually correlates with increased severity and duration of hospitalization, and that this is actually highly sensitive and specific. And now I'm briefly going into another aspect, that is a search for biomarkers. We have studied some cytokines in both dengue and chikungunya. Both of these diseases in the early phase of infection present very similarly, and there's no differentiation. Here we looked at a spectrum of cytokines like IL-6, IL-8, IL-10, tumor necrosis factor alpha, and interferon gamma. And to cut the story short, we found that IL-6 was elevated in both the viremic and non-viremic. We have categorized the patients based on the real-time PCR as viremic and non-viremic. And we found that IL-6 was a good marker for chikungunya infection. And that when we looked at dengue, we found that there was some difference in the viremic versus non-viremic group, where IL-8, IL-10, and tumor necrosis factor alpha were more increased in the viremic group, whereas the non-viremic group, it was IL-6 and TNF alpha. Okay, I'm just cutting down to how did it perform in the context of probable dengue warning signs in severe dengue. You'll see this, that IL-8, tumor necrosis factor alpha, and interferon gamma do have a role here. And these are that there is a Th1, Th2 type of response that happens in this. And this is very critical in determining the outcome of the patient. In fact, when they have severe dengue, the Th1, Th2 response is skewed, and that results in this in the worsening of the disease. So these are characterized by IL-10, IL-6, and interferon gamma. Okay, like I said, I think in the interest of time, I will not dwell too much on this, but just to highlight here that when the CT values, and we are all very familiar with CT values since SARS-CoV-2 happened, that when the CT values are low, where there's more of the virus, the values of some of these cytokines was very high. So these are potential biomarkers that can be used for diagnosis, especially when patients are critical and other tests are not very conclusive. This is a small case report of a 32-year-old male who had severe headache, myalgia, and then progressed to multi-organ failure on the 8th day and died. He had a high viral load, and he had high IL-10 and IL-8 with low levels of interferon gamma. Actually, interferon gamma is protective, and when these are high, patients do recover. So I think this has got also immunotherapeutic implications then. So to summarize, there is definitely a role for biomarkers in both chikungunya and dengue. In chikungunya, we believe there's a role for IL-6. In dengue, we believe that there's the role for IL-8, and that interferon gamma, if it is elevated, has good prognostic implications. And also definitely the need for, other than NS1 in detection, the need for doing the viral estimation by real-time PCR. So there's a continued need for surveillance. Increasingly, diseases are presenting with complex or atypical manifestations, and infectious diseases are no exception. A true understanding of the implications of the impact of an infectious organism on individuals and community requires the integration of multiple specialties like microbiology, immunology, clinical medicine, epidemiology, psychology, geography, anthropology, zoology, and many other disciplines. And that actually is happening in today's world when we deal with COVID. So this is again important way forward, not just for COVID-19, but for all the infectious diseases that we encounter in our country. I'd like to conclude by saying that we started for our journey at Srihar with, in fact, not even a stapler when we were going to establish this molecular biology lab. And I have to acknowledge the, immense support and the privilege given by the management of Srihar and the administrators, as well as the Dr. T. Jacob Don, Dr. G. Sridharan, who's no more and who's my mentor, Dr. Gagandeep Kang, Dr. Rajesh, Dr. Asha, and Dr. Priya Abraham, all of whom who have been phenomenal in their support for our endeavors at our institution, and others at King Institute, as well as those abroad. This is Dr. Gopal Swami, who received his PhD and who has been working with us for several years and now has joined Bharat Biotech, and whose PhD work I have quoted here. This is the entire support staff here, and we believe we can achieve great things, just like Kapil Dev did with the World Cup. And Monica is now at Johns Hopkins. She's completed a PhD from here, and that's really good for us because she worked in an area of hepatitis B. Some of these people have moved on, but they all contributed immensely to the work and are therefore here as acknowledgement. We also have collaborations with institutions abroad and have been appreciated in our works. This has been our journey. I'm sharing this just that because we were keen to start PCR in diagnostics way back in 2005-8. We started with H1N1, received NABL accreditations. Because we have a transplant program, we moved into all the herpes group of viruses, chikungunya also, because of one of our collaborators' interest in that. And then we moved to the bloodborne pathogens. And finally, now we're also doing genotypic and drug resistance. And we are training students in MSc Medical Microbiology and BSc Honors Medical Microbiology and Applied Molecular Biology. And these are very, very well sought after courses. We also run an MD PhD program supported by ICMR for the institution, other than the regular PhD program. Thank you once again for this great opportunity.
Thank you, Dr. Padma Shrikant. A very common man questions are in my mind. I want to ask you, when should I suspect dengue?
Yeah, that's a really good question, ma'am, because when there is high grade fever and when there is body pain, severe myalgia, I think day 2, day 3, day 4, it's very important to start the tests and look first for dengue. If dengue is negative and we have, the other lepto, malaria, I think probably simultaneously look for malaria. Now, the patient's history should be very carefully elicited. Many of them complain of retroorbital pain. So that's an important history to elicit. If that is there, it's a very key pointer to dengue, but not all of them have it. There is a fever with rash, and then, of course, the presence of mosquitoes, mosquito bites. Often it happens in travelers. So I have to be alert with all that in mind.
One more question in my mind as I'm seeing the scenario since 2 years, that are we ignoring dengue in this pandemic?
Yes, definitely. We are ignoring many of the pathogens. For some reason, bacterial infections have reduced, but hepatitis B is there. So That's a bloodborne virus. It's not getting eliminated. HIV is there. And of course, dengue has resurgence has happened with a, you're seeing every day in the news how it's making an impact. And the monsoon months. So there is a definite seasonality to dengue. The moment monsoon hits, and that's different in different parts of our country. So we can really, do with proper surveillance, estimate when cases will happen, and really be prepared for diagnostics as well as preventive measures, so that we do not have a fatal outcome.
Okay, ma'am, thank you. One more question in my mind. Is there any vaccine for it?
Yes, ma'am, there's a vaccine. This is it's been used in Mexico, but it's not doing too well because the efficacy is somewhat limited. So it's not caught up as much as it should.
Arjun said, regarding questions, if you have any question related.
Yes, dengue, like I said, and Dr. Shrikant would be aware that we at J.Mitra, we are in the field of dengue diagnosis. And ma'am, that presentation that you made just now, it went into a level of detail which with perplexing, because there is so much more that can be done in dengue diagnosis, especially with respect to the cytokines, and they have been neglected. Let me be very honest. This level of dengue diagnosis has been neglected so far. We've got a rapid, we've got ELISAs, and everybody just goes with that particular flow. But if you see the trend of the presentations that has been happening over the course of the last 1.5 days, we are all looking at the future. And in the future, I believe that there are two parts to dengue that are critical, which are still a failure at everyone's end. One is predictability. There is absolutely no predictability of dengue in terms of its occurrence, in terms of its outbreak. 2019, we had certain states which had an outbreak. 2020, it was neglected because of COVID-19. And this year again has seen an extreme resurgence of the dengue virus. So I believe that we need to work on predicting. We have a system which predicts the weather. The same thing I think is applicable to dengue as well, because otherwise we are always going to be catching the short end of the stick, right?
True.
And
I think it's important to establish surveillance centers. I know the government is doing that, but I think you can engage. I mean, J.Mitra and such can engage private institutions and laboratories who are focused on not just diagnostics, but also being one step ahead. Trying to determine how to address this and how to predict. So there is a way, because these are cyclical. There are periods when there is a lull and we don't get so much of dengue. So these are environmental factors. So finally, what determines whether an infectious disease is going to emerge is the interaction between host agent, the human host, the infectious agent, and the environment. And that's a complex interplay that really nobody can predict. So if we have continued surveillance, that is really important. And the serotyping of dengue, I think that's an area that we are really not looking. It happens in pockets.
If you remember, last year in May, 2021 May, in the state of Florida in the US, there was an American company by the name of Oxitec. They had, as news reports suggested, released genetically modified mosquitoes to combat dengue. It was surprising because dengue is not specifically a disease of North America. It's specifically a tropical disease. Do you see that? Do you ever see that happening in India? Us going down the genetically modified mosquito way?
That's a tough call to answer. But one thing I do know is a neighboring country of Sri Lanka could eradicate malaria. So I think we can, work on eradication. We have eradicated polio.
Yes.
And we can get there. So it's just more focused energy, and possibly the thrust has to come from all key stakeholders. Right. If like it happened in the case of HIV too, the rapid detection of HIV, the immediate education and awareness. And we were able to get ahead of the HIV pandemic in the country too.
It's basically going to involve a lot of stakeholders taking
Correct.
rapid decisions and
Yes.
sticking to those decisions, I guess.
Yes, yes. And it's there in the tropical countries. It's our problem. We need to do something. We shouldn't look for the West to provide these solutions for
Absolutely,
us.
absolutely. There was a question from the audience, if I may take a minute of your time. Mr. Manish Pathak has asked, can only high-grade fever with nausea be a symptom of dengue?
No, there's also this very severe headache that can be there. The fever need not always be high grade. In fact, the secondary dengue cases are the fever is low grade. So there are some of these cytokines or byproducts of the pyrogen and producing, and so they cause the fever. But there are times that the fever is of a low grade. The primary infection is more characterized by high grade fever.
Ma'am, during your study for dengue, when you've gone into a lot of depth out here, you've done a deep dive into that study, you would have seen that there would have been a lot of times when the test results, be it rapid or even an ELISA, were not correlating with clinical symptoms. Have you observed that, if I may ask?
Correct. That's why we've been looking at these cytokines. Now, wherever we found that, see, I finally would like to convey this, that dengue seems to be more like tuberculosis. We need to use multiple tests to arrive at a diagnosis. In tuberculosis, we do smear microscopy, we do culture, we do gene expert, then we do the PCRs, and there is X-ray and CT and so on. So there is a need to use a multi-pronged approach here too. You start with NS1, you look at IgM, IgG, you absolutely must start doing more of PCRs, real-time PCR for detection of the virus. We need to also explore that there is some other antigenic component in the virus that can be detected additional to NS1. See, we're saying NS1 can pick up 90%, but actually when you find them in the clinic and NS1 is negative and it's still dengue, how can we bridge that gap? So I think we have to look at what else is there in the viremia component and try to look at addressing all those aspects. So that, that first 5 days, we have real-time PCR once time being performed, and these are not expensive. See, right now, COVID testing itself is coming down to 700, 800 rupees. So these can, with primers and probes made in India, the cost can be really low. And we have NS1. Yeah, I think between these two plus additional target regions of the antigen, we can improve the diagnostic efficiency of the test.
Thank you, doctor. Thank you, ma'am. Vidiji, before we finish, I said, let me just take 2 minutes and 1 second. Dr. Shrikant, thank you for your time and effort, ma'am. Thank you very much.
You so much.
And somebody from our Chennai team will be over to deliver the hard copy of the certificate to you very soon.
Thank you so much.
Thank you, ma'am.
Thank you, Vicky.
Thank you.
Right. Ma'am, I want to say something for you, as if I'm going to write ETC, it's mean end of thinking, my capacity. And but I know if you are writing that ETC, it's mean there are some etc. As we have seen, you were skipping slides because of timeline, and your knowledge is quite vast. And I think we have not captured everything today. I wish we will get some more time to sit with you for this. Thank you, ma'am. Thank you, Dr. Shrikant. And I'm sure participants must have tremendously benefited from your deliberations. Thank you. Thanks a lot once again, ma'am. Thank you. Now, with moving forward, I'd like to call our another speaker with these words: never stop learning, because life never stops teaching. And this happened with the doctors and with this doctor also. I'd like to call Dr. Smita Shevade. She is head microbiology and molecular diagnostic at Dr. Jariwala Laboratory and Diagnostics, Mumbai. Her topic is current practices and challenges in the field of vector-borne diseases like that leptospirosis, dengue, and malaria. So, with due respect, we would like to call Dr. Smita. Ma'am.
Yeah. Good afternoon, everyone.
Good afternoon, Dr. Chevde. You can share your screen, ma'am.
Yeah. Wait a minute. Can you see it?
Yes, ma'am. We can
Yeah,
see
ma'am.
your slides.
Yeah. Slideshow.
Yes, ma'am.
Can you see that?
Working
Oh.
fine.
Okay. Can we start?
Yes, please. Please go ahead, ma'am. All yours.
Yeah, thanks. Good afternoon, everyone. First, I would like to thank J.Mitra for inviting me as a guest speaker for TIDE 2021. I would like to thank Dr. Zariwala and Dr. Zariwala Laboratory for giving me this opportunity to present this presentation. My today's topic is current practices and challenges in the field of vector-borne disease, like that of leptospirosis, dengue, and malaria. Vector-borne disease. So, what are vector-borne disease? Vector-borne disease are the disease that results from an infection transmitted to humans and other animals by blood-feeding arthropods such as mosquitoes, ticks, and fleas. 80% of world's human population is at risk of one or more VBDs. Currently, approximately 20% of global topical infectious disease burden is vector-borne, and this accounts for about 1 million human deaths annually. Now, when we say vector-borne disease, what is vector? Vector is an arthropod or any living carrier that transports an infectious agent to a susceptible individual. Epidemiologically, vector-borne diseases are classified as those transmitted by vector, by transmission chain, by methods in which vectors transmit agent, and then by methods in which vectors are involved in the transmission and propagation of parasites. Now, first one is by vector. So vector, either it can be invertebrate type or vertebrate type. Here is the list. By transmission chain, that is from man with a non-vertebrate host, man, vertebrate host and non-vertebrate host, and man with two intermediate hosts. By methods in which vectors transmit agent is by biting, regurgitation, scratching, and contamination of host with body fluids of vectors. Fourth one is by methods in which vectors are involved in transmission and propagation of parasites. This can be by two types. First is mechanical transmission and second is biological transmission. In mechanical transmission, there is no development or multiplication of infectious agent on or within the vector. In biological transmission, again, it is divided into three modes, that is propagative, cyclopropagative, and cyclodevelopmental. In propagative, the agent multiplies in vector but no change in form. For example, plague bacilli in rat fleas. In cyclopropagative, the agent changes in form and number. For example, malaria parasites in mosquito. In cyclodevelopmental, the agent undergoes only development but no multiplication. For example, microfilaria and mosquito. So here is a list of vector-borne diseases. There are different vectors like mosquito, sandfly, blackfly, fleas, lice, tsetse fly, bug, tick, aquatic snail. And these are the different vector-borne diseases caused by them. Mosquito causes malaria, lymphatic filariasis, yellow fever, dengue, Japanese encephalitis, chikungunya, Rift Valley fever, West Nile fever, Zika virus disease. Sandfly causes leishmaniasis, sandfly fever. Blackfly causes onchocerciasis. Fleas cause tungiasis and plague. Lice, typhus, and louse spawn relapsing fever. Tsetsefly human African trypanosomiasis. Bug causes Chagas disease. Tick leads to Crimean Congo hemorrhagic fever, Lyme, tick-borne encephalitis, relapsing fever, tularemia. Snail leads to schistosomiasis. Now, these vector-borne diseases, whether they are emerging or re-emerging diseases, yes, they are under emerging and re-emerging diseases. So, what are emerging diseases? Emerging diseases are the diseases recently identified or previously unknown infections that cause public. Re-emerging diseases are known as diseases that reappear and increase in incidence, but that in past may have fallen to levels so low that they are no longer considered a public health problem. Now we are facing new diseases with new problems. For example, drug resistant malaria. This drug resistant malaria occurs due to two things. First one is resistance of Plasmodium species to anti-malarial drugs, and second is resistance of Anopheles mosquitoes to insecticides. Now, when we see vector-borne disease, are they really serious? No, they just cause fever and treatment is symptomatic. Mostly they will cause fever along with the rash. They are not that serious. Just take the antipyretic and get it cured. No, it's not like that. Whether they can cause shock, yes, they can cause shock. For example, in dengue shock syndrome. Whether they can be fatal, yes, vector-borne diseases can be fatal. So, example is cerebral malaria, dengue hemorrhagic syndrome, leptospirosis, plague. Can they lead to outbreak? Yes, they can lead to outbreak like plague, Crimean Congo hemorrhagic fever, Zika virus. Can they cause cancer? Yes, they can cause cancer. For example, schistosomiasis. Now we will turn the pages of history where we have seen outbreaks caused by vector-borne diseases. In 1897, there was a bubonic plague ravaged in India. In 2011, there was an outbreak of Crimean Congo hemorrhagic fever in Gujarat, killing 4 people, including a doctor and a nurse who were involved in the treatment and were in close contact with the patient. Recently, we have seen outbreak of Zika virus in South India. Now, what is Zika virus? Zika is spread mostly by the bite of an infected Aedes species mosquito, that is Aedes aegypti and Aedes albopictus. These mosquitoes bite during day and night. Zika can be passed from a pregnant woman to her fetus. Infection during pregnancy can cause certain birth defects. Zika virus is sexually transmitted. There is no vaccine or medicine for Zika. Now, which are the factors responsible for causing vector-borne disease? Rapid uncontrolled urbanization and population growth, overcrowding, climate change, pathogen evaluation, and deteriorating vector control. Now, vector-borne disease and monsoon, there is a correlation. Why vector-borne diseases are more prevalent in monsoon season? Because there is high prevalence of infective vectors, increased human vector contact, temperature and humidity, prolonged rain, stagnant water, floods, abundant growth of vegetation, sleeping habits of human, density and biting patterns of vectors. Now, government has launched National Vector-Borne Disease Control Program, NVBDCP. This is an umbrella program for prevention and control of vector-borne diseases. NVBDCP covers 6 vector-borne diseases: malaria, dengue, chikungunya, Japanese encephalitis, Kala Azar, and filaria. It has not included leptospirosis because it is mainly caused by transmission of contact with rat urine. This program includes 3-pronged strategy for prevention and control of VBD. First one is disease management, including early case detection and complete treatment. Next is integrated vector control management, including indoor residual spraying in selected high-risk areas. Third one is supportive interventions, including behavioral change communication. Now, what are the clinical features for vector-borne diseases? So main vector-borne diseases which we see in our daily practice are malaria, dengue, and chikungunya. Along with that, some rare diseases like scrub typhus and leptospirosis, which is more common in region like Mumbai. So these five vector-borne diseases, these are mainly seen in monsoon. All of them are causing fever. So how will we will differentiate them clinically? So malaria will cause fever with chills and rigors along with splenomegaly. Dengue, high-grade fever, retroorbital pain, petechial rash, and bleeding manifestation. Chikungunya, high-grade fever, arthralgia, and itchy rash. Doubling up, that is excruciating joint pain, is seen in case of chikungunya. Leptospirosis will also cause fever, but along with jaundice and conjunctival suffusion. Scrub typhus will cause fever, rash, and ishrar. Now, if we see the complications, then ARDS, that is acute respiratory distress syndrome, is observed in malaria, dengue, leptospirosis, and scrub typhus. Renal failure is seen in malaria, leptospirosis, and scrub typhus, whereas encephalitis is seen in dengue, scrub typhus, and leptospirosis. If we see hematological manifestations, in malaria, there is anemia and thrombocytopenia. In dengue, there is leukopenia and thrombocytopenia. In chikungunya, there is leukopenia. In leptospirosis, there is leukocytosis and thrombocytopenia. Whereas in scrub typhus also, there is leukocytosis and thrombocytopenia. If we see the biochemical parameters, then in malaria, there is increase in unconjugated bilirubin and hypoglycemia. In dengue, there is transaminitis. In leptospirosis, there is increase in conjugated bilirubin and renal failure. And in scrub typhus, the RFT is deranged that leads to renal failure. Now, what is the laboratory diagnosis for vector-borne diseases? First one is malaria. So malaria can be diagnosed by three methods: hematological, serological, and molecular. In hematology, mainly by peripheral smear, thick smear, and thin smear. Serology by malarial antigen, Plasmodium vivax and Plasmodium falciparum. Molecular by malaria PCR. These first two methods, that is peripheral smear and malarial antigen, diagnoses majority of cases of malaria. So there is no much need to go for molecular diagnosis in case of malaria. These first two cases can diagnose malaria at the level of peripheral healthcare center also. Next is dengue. Dengue, two types of tests, serological and molecular. In dengue, first one is dengue NS1 antigen ELISA, that is early ELISA. Dengue immunofluorescence assay, that is IFA. Dengue IgM capture ELISA. Dengue IgG capture ELISA. And dengue PCR. In chikungunya, serologically chikungunya antibody and molecular chikungunya PCR. Japanese encephalitis. This is detected by Japanese encephalitis IgM capture ELISA. Second one is conventional antibody assay. Where in this assay, we take paired sera and we show rising titer. Next is dot blot IgM assay. After that, there is Kala Azar, which is mainly detected by microscopy, that is demonstration of LD bodies. Aldehyde test of Napier, it is not used for the diagnosis, but it is used for the surveillance. In serology, direct agglutination test, RP39 dipstick test, ELISA, indirect fluorescent antibody test. Next is Leishmanin test. It is based on skin reaction. Filaria. Filaria, the diagnosis is mainly by peripheral smear, thick smear, and wet mouth. In scrub typhus, the diagnosis is by two methods, serology and molecular. The tests are Well-Felix test and scrub typhus IgM ELISA, and molecular rickettsial PCR. In leptospira, the diagnosis is by microscopy, dark field microscope, direct immunofluorescence, and silver stain. Culture, which is rarely done. Serology, leptospira IgM ELISA, microscopic agglutination test, hemagglutination test, ELISA, CFT. Amongst molecular tests, leptospira PCR. Now we know the different tests used for the diagnosis of vector-borne diseases. Now, which test should be done when? Suppose if it is a malaria and the test is a thick smear, then it should be done at the onset of fever at the peak of rigors prior to the start of anti-malarial treatment. If it is a malaria antigen, it should be done where microscopy is not possible. These two tests are comparatively easy and they diagnose majority of malarial parasites, and they can be done at the level of periphery also. Malaria PCR is only required when there is early diagnosis, but it is a costly test. In dengue, there are four tests: NS1, and IFA. This NS1 and IFA is done in less than 5 days of onset of fever. Dengue IgM ELISA is done after 5 days of onset of fever. IgG ELISA after 14 days of fever, and PCR within 7 to 10 days of onset of fever. Chikungunya is done before 5 days of onset. Chikungunya PCR is done before 5 days of onset of fever, and IgM ELISA is done after 5 days of onset of fever. In microfilaria, the test is demonstration of microfilaria. So microfilaria can be of two types: those who are having nocturnal periodicity and those with non-periodic variation. So nocturnal periodicity, in these cases, the blood is collected between 10 p.m. to 2 a.m. And for non-periodic microfilaria, blood is collected at any time, preferably in the morning. In leptospira, culture is done. If culture is done, there are two samples. If it is blood, then it should be done within 7 to 10 days of onset of fever. If it is a urine, then culture should be done after 1 week of onset of fever. If it is a PCR for leptospira, then it should be done in the first week of onset of fever. If it is a IgM ELISA for leptospira, then it should be done in the second week of onset of fever. Now we know the different methods. So what are the advantages of these different methods and what are the disadvantages? So these methods are mainly classified as conventional or classical methods, serology based methods, nucleic acid based methods, omic based methods, and multiplex methods. In conventional methods, the most common is the microscopy and a smear examination. So it requires a simple equipment and reagent, and it is suitable for resource limited settings. Now, disadvantages, it is labor intensive and time intensive. In conventional method, another thing is pathogen isolation and cell culture, but expertise is required for it. In serology, IFA, ELISA, HEFT. In serological tests, the sample collection is easy and mostly the reactivity. In nucleic acid based methods like PCR, RT-PCR, FISH, LAMP, there is increased sensitivity and specificity. There is a speed in diagnosis, but the equipment and reagent are costly. They require a modern state-of-art setup. In omic-based methods, that is genomic sequences, these are high throughput analysis. They have increased sensitivity and specificity, but again the disadvantages is that the equipment and reagent are costly and expertise techniques are required. Then multiplex PCR, then multiplex methods, that is multiplex PCR, microarrays, they are useful for detection of co-infection, high throughput analysis. Now, in our lab, we have done a comparison between dengue NS1 antigen ELISA and FIA. So we have found that sensitivity of FIA in comparison with ELISA is 100%. True negativity is 100%. Sensitivity of ELISA was found to be 92%, while that of sensitivity of FIA was found to be 100%. Specificity of FIA was 100%. Here we represent the laboratory data of our lab in this year in monsoon season. This includes 4 months, July, August, September, and October. So first test is malaria. So malaria we diagnose by slide test, malaria antigen, and malaria DNA PCR. So what we have observed that majority of cases of malaria, suspected malaria, were present in the month of September, and majority of cases were positive during the month of September. In dengue, there are 4 tests: dengue NS1, dengue IgM, dengue IgG, and dengue RNA-PCR. So majority of cases of dengue were suspected dengue cases were found in the month of September, but majority of positive cases were found in the month of August. Chikungunya, last year as compared to last year, chikungunya cases were more this year, and more number of cases were observed in the month of October. Out of 40 chikungunya cases by PCR, 18 were show positivity. Rickettsia, although it is a rare disease, still we have measure to diagnose it. So one is well-Felix test and second is scrub typhus IgM. Well-Felix, although it is non-specific, our majority of tests showed positive result except for the one. Whereas scrub typhus IgM showed positive result only for one test. Leptospira, we detected by Leptospira IgM. In the month of October, out of total 7 Leptospira cases, 6 were positive. For the detection of filaria, we have a microfilaria demonstration, but we could not find any microfilaria case up till now in this year. The same thing we have represented in a graphical format. So from here we can see this malaria suspected cases are more both in vivax and falciparum as compared to any other vector-borne disease. When we say the positivity rate, then dengue cases were showed more positivity rate, and these were mainly detected by dengue NS1 antigen. Now, when we release the report of a vector-borne disease to our clinician or a patient, they start asking us the queries. This year, as the chikungunya cases were more, we got the queries because chikungunya, once the treatment is over, still the symptoms persist or arthralgia persists. So it takes time to went away the arthralgia. So there is a chikungunya antibody test, and chikungunya antibody test, here is the interpretation. If IgM and IgG both are negative, then it is no infection. If tested soon after symptom onset, then retest at least 10 days later. If IgM is negative and IgG is positive, then it is a past infection. If IgM is positive and IgG is negative, then it is acute or recent infection. Then retesting using a sample collected at least 2 weeks later can confirm presence of IgG antibodies. Then IgM positive, IgG positive, recent or past infection. A 4-fold rise in IgG titer in a specimen collected at least 2 weeks later is consistent with recent infection. Now, in our laboratory, along with the human cases, we get veterinary samples also. In those samples, we have observed a rare vector-borne disease, that is trypanosoma species, in a CSF of a dog. And here is the picture. Now, vector-borne disease and COVID-19. Since last year, we are facing the pandemic of COVID-19. In last year, when there was a fever, the only diagnosis was COVID-19. Rest of the diseases did not come up. Maybe the reasons may be different, but this year we could find different diseases producing fever like that of vector-borne diseases or typhoid. Now, what is the common factor between vector-borne diseases and COVID-19? One thing is that both of them are fever producing. Second thing, there can be co-infection and cross-reactions. Now, what are the challenges faced in the diagnosis of vector-borne diseases? So there are plethora of symptoms, overlapping of clinical presentation. As fever is common in all vector-borne diseases, This is the one thing. Then fever with rash is seen in dengue also. Fever with rash is seen in scrub typhus also. Atypical manifestations. Then diagnostic dilemma, non-availability of diagnostic. If someone is sitting at the periphery and he come across the case of a vector-borne disease, then immediate prompt treatment or availability of prompt diagnostic facility may not be there. Then empirical treatment is over treatment or promote antimicrobial resistance. Then ICU admission, high treatment related cost, high morbidity and mortality. Now, in the case of a vector-borne disease, the history is important, because when we say fever, there are 52 reasons why the fever is produced. But when this is in monsoon region, then monsoon season, then we suspect it is a vector-borne disease. If it is a vector-borne disease, which history we should ask? So we should ask for the history of onset of illness in relation to known incubation period. Is there any pattern of fever? Is there any peak in fever or dip in fever? Fever with rash, first day fever, rash fourth day, or third day fever, fourth day fever. Accordingly, we can classify the diseases based on their clinical findings. Then associated clinical symptoms. Then localizing clinical symptoms and signs. Headache, periorbital pain, altered sensorium, myalgia, conjunctivitis, keen rashes. Geographic location. Here we also should consider whether the person is staying in any dormitory or any hostel facility where there is overcrowding, where there is a chance of ectoparasites or bugs which can lead to diseases caused by these vectors. Then traveling history is important. If it is within the country, whether he has returned from any specific endemic zone. Suppose he is returning from UP or Bihar, if it is the case of a Kala Azar. Travel history outside the country, for example, in case of trypanosomiasis. Then knowledge of recent outbreaks. That means we know recently there was an outbreak of Zika virus. Then history of pet exposure. Pets usually sometimes if they are infected, then fleas and ticks are there. Those who are in close contact with pets, they can get the diseases caused by these pets. Then a history of insect bite. Occupation history. Whether the person is a farmer, then there are chances that he will get vector-borne disease. Now the treatment. In case of malaria, we know anti-malarials are given. The treatment is chloroquine and quinine. If it is chloroquine resistant, then artemisinin is the treatment. In case of dengue, the treatment is symptomatic and supporting, and antipyretics are given. In case of chikungunya, there is no specific treatment. Analgesic and antipyretics are given. In leishmaniasis, sodium stibogluconate. If it is resistant to that, then maltefosine and amphotericin B. In case of filaria, the treatment is diethyl carbamazine. In case of leptospira, the drug of choice is penicillin. If it is resistant, then tetracycline and doxycycline. To conclude, vector-borne diseases are mainly seen during the monsoon season. There is a correlation between vector-borne disease and a monsoon, that is the climate. Then dengue is most commonly suspected vector-borne disease in our setup. Chikungunya cases, suspected cases were more commonly occurring as compared to last year. This year we have observed in our lab. Chikungunya suspected cases were more in the month of October this year. We should be vigilant for rare vector-borne diseases. In case of veterinary samples also, vector-borne diseases should be back of the mind. So this was regarding vector-borne diseases. Thank you.
Thank you, ma'am.
Thank you
Is
very
there
much.
any question from your side?
Yeah, thank you very much, Dr. Shevde. Very
Yeah.
insightful presentation, and you've covered a plethora of diseases You've covered not just one or two, you've covered the entire spectrum of vector-borne diseases. This there's always this question in my mind. In fact, based on the data that you were showing, you showed us some data which said that for chikungunya, in the month of in the month of for dengue, you had more positives in August, but
Yeah,
less positivity, but more number of testing in
yes,
September. So what would be your
yeah.
analysis as a conclusion? What would come out of that? What would be your thought process on that?
See, in the month of, see, we have seen positivity number of suspected cases more in 1 month, and positivity rate was more in other. That might be related to the heavy rains in the month which was with a heavy rains. At that time, the positivity rate was more, and in the next one, they were suspecting because it is a fever. So that was the season. So more number of tests were requested. That can be a reason.
Could be. Yes, I understand. Ma'am, there's a lot of talk of climate change, and I was in Bombay recently. It's still raining. Every now and then
Yeah,
it's still raining. So
yeah,
there is a definite shift in the way the mosquitoes will breed, behave,
correct.
and the propagation of these vector-borne viruses. I believe that we are looking at instead of just the monsoon, because the monsoon for us, and I am from Bombay, so I know it's June to
Yeah.
September is monsoon, right? But now it's September, October, November. The monsoon has got stretched out. Oh, do you think this will affect going forward? It will affect the incidence of vector-borne diseases as well?
Yes, because since last 2 3 days we are also saying that it's raining. It's raining almost heavily, just like a monsoon season. So we were also thinking that again we were about to say that no, okay, now the vector-borne diseases are declining, but again we are thinking that they will again peak for some days till the rain is there, and let's see if it should come down.
Yeah, there was one more question, ma'am, and this was
Yeah,
it's been asked. It was on my mind. In fact, I'd written it down, and one of my participants has also asked it.
yeah,
That most of these vector-borne diseases have a fever as one of their key symptoms,
yeah.
right? So how can we categorize? How do we choose which one comes first in terms of the differential diagnosis of fever during monsoon season? How do we test? What do we test for first? How do we test second? What do we do as a priority?
If it is a fevers, see, the most common occurring is malaria, dengue, and chikungunya. So these three you should be keep on priority. So first fever, CBC is also there. Then first is PS for MP, peripheral smear check for the malaria. First get the test done for the malaria. If the presentation is not typical, then you have to rely on your diagnostic test, because nowadays these diseases are not giving any typical sometimes presentation. So first is get it malaria done first. If it is negative, then go for dengue. And if you are from the area where there is a chikungunya cases are more, then you can think of chikungunya also. That is what I think.
Right, ma'am. Ma'am, is it possible in case of a secondary infection of dengue, when where we are looking mostly at IgG, is it possible for the sudden drop of NS1 antigen to a negative range within 24 hours? How fast is the NS1 drop? Because in primary infection, it's there for 6 to 7 days. In secondary
Yeah.
infection, what is the incidence of NS1 detection, ma'am?
Uh, See, as per my knowledge, NS1 is detected only in early cases. So I'm doubtful whether it can be detected or not.
Right, ma'am. And one last question that
Yeah,
we have from a member of the audience. As we all know, more than 1,000 pathogens can cause infectious diseases. A
correct.
hypothesis free approach based on NGS, that is next generation sequencing, is
Yeah.
probably the best approach. In your opinion, ma'am, what is the main limitation of an NGS based test in India?
See, one thing is cost. Second thing is setup. Third is expertise, trained person. It is while doing it is little bit time consuming. So it will take time to get trained, and interpretation is going to be little bit difficult as compared to PCR, because it is the next stage of PCR. So it is multiplex, because each comb you have to see. So it is going to be difficult, but we can do it.
Right. Thank you, doctor.
But I
Yeah.
don't know for NGS how much diagnostic importance, whether clinician will directly prescribe NGS, because recently they are ready to prescribe PCR. So it will take time
Yes, absolutely.
whether they will write directly on their prescription pad NGS, do the NGS.
I think, ma'am, as we go through, as if you look at the last 10 years, there's been a sea shift in in the diagnosis industry also. So I'm sure over a period of time, new technologies, new thought processes, and uh, whether say NGS-based testing or something chip-based testing, we will see the advent of it. It's just a matter of time.
Yeah,
So,
actually, they are adapting the new techniques, because if they want very early urgent diagnosis, if suppose the patient is in ICU, or if he or she is critical, so they are thinking of a test. Let it be a costly, even the relatives are also ready to pay. At that cases, if it is good for the health of a patient, then we can think of it.
right. Thank you, Dr. Chevre. Thank you very much. Ma'am, one of my managers in Bombay will be in touch with you very soon to give the actual certificate. But for now, let us please allow us to show appreciation, the small certificate appreciation, digital certificate. Thank you for your presentation, ma'am, and thank you for your time and effort.
Thank you, thank you, thank you so much. Thank you so much.
Thank you, ma'am.
Over to you, Vidiji. All yours.
Thank you. Thank you, Arjunji. Thank you, ma'am. This will be the now sincerely going for the last session of the day. We have Dr. Upasna Bhumla. She is Associate Professor and Member Secretary at Adesh Institute of Medical Sciences, Bhatinda. She will be sharing her expert views and insights on the recent advance in malaria rapid antigen test versus microscopy. The participants may put their queries in our chat box, and at the last of the session, she will answer of your questions. Over to you, ma'am.
Well, hello, good evening, everyone. I hope I'm audible to everybody.
Yeah, ma'am.
Yeah, great. Good to go. So probably last but not the least, the session I have to chair. And the most important thing, first of all, I should thank you, the team of J.Mitra, for giving me this platform. I'm thankful to Dr. Neeraj Jain again to sharing this platform with me and allowing me for a very important topic to be discussed as a part of microbiology. I think I'll try and justify how it is. Sir, if you allow me, I can just have a word about last speaker, whatever madam has actually shared with. Coming from the medical college side, I have worked in both the lab and the medical college. So there are many glitches that we actually face. So there are a number of queries which are coming like next generation sequencing, people are talking about it. So here I would like you to ponder it. When this COVID started, so the starting of this RT-PCR lab, the BSL-2 level labs, the National Medical Council, the MCI itself has provoked it, saying that yes, every medical college, whether it's a limitation of 50 seats, they have to have this BSL-2 level lab, which is very important to know here. Otherwise, I don't think so how many setups actually had their RT-PCR setups with them. So with the emergence of COVID, we had this. So at the same point of time, if I just hope this Omicron should not, prevail into the system even more. Otherwise, I think the next clarification probably would be for this NGs, which probably a simple corporate lab, I don't know how much they will be able to justify it, but for a medical college, it will become mandatory. And then the clinicians have to rely on NGs also. And it will become a boon just like RT-PCR. It became a star overnight, RT-PCR. So as Dr. Gaur very correctly, he had said that within very short span of time, even a layman can now say that COVID karwana hai, matlab RT-PCR karwana hai. So it is very tricky if at all this is going to be the next scenario with Omicron. So
absolutely,
over to that,
because,
right.
Like you just said, we are living in a time where the changes are happening very, very fast. Transformation is almost overnight, if I may say so. In a matter of speak, if you look at timelines, 20 years ago versus timelines today. It's taken us a year to internalize the concept of PCR, which before the COVID had been a fading technology in terms of applicability, the number of people using it. Today, it's a household word, and everybody from top to bottom in the economic strata is familiar with it.
Exactly. And the economic and the technical glitches what we face using the RT-PCR, and for next generation sequencing, it's even more difficult for the technicality part, for the doctoral part, and even for the setting up of the whole lab for NGs. That's important. Well, over to me as I have to talk about malaria. Yeah, malaria and the recent advances in malaria. There are lots. Like if you're talking about the 20 years back scenario, yes, there were certain things which were just there on the microscopy part, and there were certain things then affectionately or not affectionately, I had to actually say that yes, malaria has been a constant in our life. It is the oldest documented disease which is there prevalent in the mankind. If we derive it, whenever we read about malaria, this is the first probably line. I think we have read it everywhere. And Mr. Dr. Leveran in 1902 and Sir Ronald Ross in 1907, they had the contributions and they were given Nobel Prize for the same in the field of malaria also. So let me share my screen with you all. So today I'll be talking about malaria and update on its diagnosis, mainly about the light microscopy over the rapid diagnostic test availability, which is prevalent in our system. Okay, moving on very quickly. 1 second, sorry for the glitches. Okay. The causative agent, I think I don't have to mention here. It is Plasmodium, and it belongs to the member of Epicomplexa. There are 5 important species which are known to the humankind. Earlier it was 4, and thanks to the mutations, thanks to the availability of the mosquito and the prevalence of the pathogenesis of the disease, now we have the 5th one with us, that is Knowlesi. So Falciparum, Vivax, Malaria, Ovale, and Knowlesi are the 5 important species infecting the human race. Overall, if at all I talk about, there is 41% of the world's population which lives in the areas where malaria is transmitted, and more than 100 million new cases of malaria are seen every year, and it is the 4th leading cause of death. If I talk about in India, it is the 3rd leading cause of death in India. I think in today's list, topping the list is COVID and COVID-19. This is a very brief distribution of malaria which is prevalent all over the world. So morphology, if at all I talk about, we have the falciparum. The most important forms are the ring forms and importantly the banana-shaped gametocyte. In Vivax, we have irregularly shaped large rings and trophozoites, ovale, infected erythrocytes, enlarged and oval tufted ends with Schnapper's dots. And malaria, the band and the rectangular forms of the trophozoites are known to us. Well, talking about Knowlesi, it's a very recent newer species which is reported from Asia and the other subcontinents also. So Knowlesi has been upcoming star, you can say that, but over the more, we can definitely have some rapid diagnostic tests in the pipeline, and it will be just like the malaria vaccine, it may hit the markets very, very soon to us. Very quickly about the life cycle, we have the exoerythrocytic cycle, where we have the erythrocytic cycle and the sporozonic cycle. The sporozoites are the mainly one which is helpful in the transmission of malaria. Talking about the clinical feature, without mentioning, I cannot move forward that yes, we have the classical attack lasts for almost 6 to 10 hours. We have the cold state, we have the hot state, sweating, and the paroxysms, if they continue, they may lead up to the complications. So the CNS, the spleen, stomach, blood, skin, muscular, lungs, it can affect any area of your body when along with fever, the complications prevail. Very quickly, if at all, I can talk about the pathogenesis of the complications of malaria. There can be cerebral malaria, there can be severe anemia, there can be hemoglobinuria, it can lead to pulmonary edema, coagulation abnormalities and thrombocytopenia, cardiovascular collapse, or even patient may lead into shock. Black water fever, I think because of the repeated infections of Plasmodium falciparum, we generally see this. And clinical features are high-grade fever, vomiting, pain in the loin, jaundice, hemoglobinuria, hemoglobinuria, and patient might land up into collapse or shock. It is mainly hitting the immunocompromised patients. Cerebral malaria, the word itself defined it, the convulsions are there, the GTCS type, patient may have into delirium, abnormal behavior, or may lead up into coma. Then we have this tropical splenomegaly syndrome. pulmonary edema, hypoglycemic lactic acidosis. Yes, these are all basically the features and the complications which we generally deal, and if the patient complicate, may lead into these complications of black water fever or cerebral malaria. One word here I really have to put down about the relapse and the recrudescence. This word keeps on juggling between, yes, it is falciparum, it is vivax. So what is relapse? What is recrudescence? I think I need to mention it here, that relapse is basically seen in Plasmodium vivax and ovale infections, wherein the reactivation of hypnozoites leads to initiation of the erythrocytic cycle and finally resulting into the relapse of malaria. Whereas the word recrudescence, it is very important to know that it is mainly seen in falciparum malaria, and it is due to the persistence of drug-resistant parasites even after the completion of treatment or inadequate treatment with antimalarials or any immunocompromised patients or in pregnancy. All these reasons can lead to recrudescence. So moving on to the main topic of discussion for today's talk, laboratory diagnosis, or how do you diagnose malaria? I think from the ages, as I said, that this is the first disease of the mankind ever knew about it. So firstly, first and foremost, as a microbiologist, as a pathology, as a lab person, I think I will concentrate on microscopy. It can be a thick smear and a thin smear, which we can make it on daily basis. It is routinely done in our clinical practices. So light microscopy of J.Mitra stain blood staining can be done, and the different stains which are available for doing the peripheral blood smear, we have J.Mitra, we have Leishman stain, we have Peel stain, which is very commonly used, Wright stain, Romanowski stain is also very commonly used in clinical practices, in laboratory practices. And then last but not the least, now an obsolete one, but still Jaswant Singh Bhattacharya stain is very important for performing this peripheral blood smear. So for microscopy, if you talk about thick smear, what ideally we are looking for in a thick smear? It should be prepared and then and there, read immediately by a concerned experienced person, either a microbiologist or a pathologist can help you out with the microscopy. The importance of thick smear lies up that yes, it can help in the detection of parasite. What parasite? That it's a malarial parasite. Then it can help in quantitation of parasitemia. On the third important and the most important point, where we can identify the malarial pigments in the monocytes or in the polymorphonucleosides, especially in the cases of Plasmodium falciparum, we can look for. This is the importance of thick smear. Talking about making it a thin smear, again, it can help in detecting the parasite. It's a malaria. Which species it is? That can be helpful. So the presence of ring forms alone or along with the gametocyte, multiple rings in RBCs with ecole formation, which is very common in falciparum. Morier clefts, it's their banana shaped gametocyte, very predominant for Plasmodium falciparum, which can be detected on a thin smear. This is a brief description of I'll point out the pigments. I'll point out in a peripheral blood smear, what are you looking for? You're looking for a trophozoite, a ring form, a schizoid, a gametocyte. Yes, here I have to mention, one second. Okay. In a peripheral blood smear for vivax, falciparum, and malarian ovale, I can start from the ring forms. Ring forms in Plasmodium vivax, yes, they are just like 2.5 micrometer in size and generally occupying 1/3 of the RBC. In falciparum, the rings are 1.5 micrometer size, which is generally smaller than the vivax, and it is generally occupying 1/6 of the RBC. So multiple ring forms, ecole forms, and double dot forms are generally seen in falciparum. In malaria, there is early trophozoite, which is similar to vivax, and Plasmodium ovale. There are again ring forms which are similar to vivax, but present inside the oval-shaped RBC. Second point is talking about the schizoid. Schizoid, if you talk about in Plasmodium vivax, it is very large in size, generally 9 to 10 micrometers in size, which completely fills up the enlarged RBCs, and it might contain 12 to 24 merozoites or schizoids in it. These are all the clinical features, what we actually look forward in the peripheral blood smear. For Plasmodium, malaria, and ovale, the size of the schizoid is 6 micrometer in size, and it fills up almost 3/4 of the RBC and contains almost 6 to 8 merozoites. In falciparum, generally the schizoid is not seen, but very rarely it can be identified. Moving on to the gametocyte, the most important one about here is Plasmodium falciparum. In Plasmodium falciparum, we have a banana shape or a crescentric gametocyte. which is larger than the RBCs, and it occupies almost the whole of the RBC in itself. So this is briefly about the peripheral blood smear, how a schizon, how a ring form, how a gametocyte looks like. Especially for the postgraduate students, especially for the younger faculty members, it is very predominant to underperform when you're speciating it. It is a schizon, whether it is a gametocyte, whether it is a ring form. If it's a ring form, which actually species it is belonging to. Okay, very quickly, I think everybody can appreciate the banana-shaped gametocyte. The next point is about the quantitative Buffet code. I'll just deal it in the next slide. These are the Morier clefts, which are there in Plasmodium falciparum, and the ecole forms. It is well demarcated by the arrows. In Plasmodium malariae and ovale, schizon are rosette shaped. There is a central pigment, and in ovale, ring forms are available. Presence of dots and clefts in the infected RBCs can be seen. Okay. Apart from the light microscope, we have fluorescent microscopy. We have the quantitative Buffet code microscopic pictures also. So in Kawamoto's technique, fluorescent microscopy or the Kawamoto's technique, generally what do we do? It is for demonstrating again the malarial parasites only. So the blood stains, rather than the normal Romanowski's or J.Mitra or Wright or field stain, it is stained with acridine orange, and it is viewed under, importantly, it is viewed under a fluorescent microscope. That we can do it under a light microscope. This is generally under a fluorescent microscope. So the nuclear DNA is stained green, and the cytoplasmic material is seen as red in color. This is a very important point, quantitative Buffet code. Quantitative Buffet code has been used over the years by the various clinicians. Quantitative Buffet code that also uses acridine orange as a dye. The QBC technique has been shown to be a rapid and a sensitive test for diagnosing malaria in numerous laboratories all over the world. The sensitivity for falciparum malaria, it is quite very high for quantitative Buffet code, and it is one of the preferred diagnostic method for diagnosing Plasmodium falciparum over the other modalities. So acridine orange stain malaria parasite appears brilliant green in color, and as less as 3 to 4 parasites per microliter of blood can also be detected by this quantitative Buffet code. If I can just depict it. The ground layer is the RBC, then we have the platelet, above one is a plasma layer. So we have this microcentrifuge, we have this microhematocrit tube where 60 microliter of blood is generally collected, and it is centrifuged. And after that, the components of blood according to the densities, as you can see it in the picture, RBCs, WBCs, and lymphocytes and platelets are generally lined up, and examination of this capillary tube at the Buffet code region under a UV ray is generally seen, and that's how the brilliant green dot, which you can very well appreciate, that they generally help us in knowing the parasitemia load. Moving on to the serological test. Why do we do the serological test? We have to identify the infected donor in case of transfusion malaria. To confirm past malaria in patients, here I will ponder the points. And for epidemiological surveys, which is the most important serological test what we can do. So first and foremost, we have this indirect hemagglutination test. Then we have this immunofluorescence antibody testing, generally known as IFA. There are many studies which says that the principle of this IFA is nothing but following infection with any Plasmodium species, where specific antibodies are produced within 2 weeks of initial infection, and which can persist for more than 3 to 6 months after the parasite clearance also. So the quantification of both IgM and IgG we have to monitor, and the titers of more than 1:200 is classified as the recent infection. More 1:20 is generally considered as positive, and less than 1:20 is considered as negative. ELISA is also one of the important modalities which is used for detection, serological detection of malaria. Very important point, since we are talking about the rapid from light microscopy to rapid diagnostics test, how much they are feasible and how much diagnostically they are important to us, how much sensitivity and specificity they carry. Yes, I think the most readily available kits are parasite, F and ICT malaria kits, which is mainly for the Plasmodium falciparum, and they have HRP2 antigen. And for falciparum and vivax, and for other species also we have this other serological tests using this lactate dehydrogenase and aldolase. The sensitivity for parasite F and ICT, I think it is mentioned here as 77 to 100%, and specificity is 83 to 100, which on top of, if you talk about the gold standard, which is light microscopy, we really have to say that 90 to 93% is specificity for light microscopy over rapid diagnosis. So that's why sometimes a glitch between light microscopy, you can definitely identify the parasite and the species also, which generally is somewhere missed in rapid diagnostic, though it is very readily used up in the society and for the epidemiological purposes also. So these were generally the kit, how a negative one looks like, how a Plasmodium vivax immunochromatographic test looks like. Some tests detect Plasmodium falciparum specific and pan-specific antigens. As I said that aldolase and LDH can be one of the. One word I want to ponder it out here. Yesterday night when I was reading, a new rapid diagnostic test for Plasmodium no lesi is also there in the pipeline. So hopefully, not by light microscopy, probably by the rapid diagnostic test, we can be able to differentiate between this 5th species of malaria. Moving on to the molecular diagnostics, I think Dr. Gore, the previous speakers have, I think, had a very extensive talk about the molecular methods. So very quickly, if at all, I can mention it out here in malaria. This, yes. Polymerase chain reaction, I would give the first thumbs up, yes, because nowadays in a medical college, definitely we have this PCR availabilities and we can think about using it. So it uses this PBRK1 primer, which is highly sensitive method and can detect as low as even 1 to 5 parasites also per microliter of blood, which is nothing but 0.001% of infected RBCs. For no lesi, they are saying rather than real-time PCR, we can use a nested PCR for no lesi. Again, not as such readily available theories are there, and the data on no lesi is not much available in on the social medias. Then we have this DNA probes. DNA probes are very important again for low parasitemia also. This can be one of the important modality. One thing about you would have heard about flow cytometry. So there is new technology called as rotating crystal magneto-optical detection, or the flow cytometry method. In this, I think the hemozoin, if I can explain it in a manner, the principle of this technique is nothing but it is based on the detection of hemozoin. So, which is produced, this hemozoin which is produced in the intra-erythrocytic malarial parasite, which eventually digests the host hemoglobin. It crystallizes heme into hemozoin into the acid food vacuole, and this hemozoin within the phagocytes can be detected by depolarization of laser light. Just the funda of flow cytometry has to work up here. And studies have shown that the sensitivity of this flow cytometry, this RMOD, is very, it is 49 to 98%, and the specificity for this is almost 80 to 90% for the malarial diagnosis. The potential use for this RMOD is in diagnosing the clinically unsuspected malaria. Sometimes you have pyrexia of unknown origin. You might be thinking about so many vector borne diseases, you have so many other viral infections also, but looking at the CBC pattern, yes, you can exclude out viral. But yes, if you're suspecting none other than malaria, but you're not able to identify the speciation, so unsuspected malaria cases can be helped out with this flow cytometry or this rotating crystal magneto-optical detection, that is RMOD. And the load of detection, again, as less as 10 parasites per microliter of blood can also be taken up with Plasmodium falciparum spike if at all you're expecting output. Okay, the next modality for in the molecular section is isothermal loop amplification. Again, one of a very good molecular malaria diagnostic test, which can detect the conserved the 18S ribosome RNA gene of Plasmodium falciparum. This lamp is eventually, apart from TB, it is very helpful for HIV and for malaria, and it is quite reliable and useful for routine screening of malaria also, which has been documented in many of the ICMR journals. But again, the setup is very cumbersome, and it is quite difficult. The technical glitches what we face in our day-to-day lives, and of course it is cost effective also, which is not everybody's cup of tea. Then another future diagnosis for this infectious disease, we have this microarrays. आज की डेट का मतलब ये बहुत important after RT-PCR we can think about this microarrays. This is pan-microbial oligonucleotide microarray which has been developed as for Plasmodium falciparum identification. It can be very, very good for point of care testing, and Plasmodium falciparum accurately in clinical specimens can be diagnosed with this microarrays. One word about mass spectrometry. Mass spectrometry, again, for in vitro detection of malaria. Again, the sensitivity to detect the load of parasites as less than 10 parasites per microliter of blood can also be detected. The principle of this, it is to identify a specific biomarker in the clinical samples, just like in hemozoin in RMOD. Again, this also picks up the hemozoin, and this with the mass spectrometry desorption, laser desorption, ultraviolet spectrometry, it can be helpful for detection of Plasmodium falciparum. Then we have a word about automated blood cell counters. In fact, there are three approaches to this. One is that cell-dyne, it's a bigger apparatus which detect the malaria pigment again, and almost it has a sensitivity which is very, very high, that is 90%. And but when compared with the gold standard, it is definitely effective, but again, the cost effectivity matters. The second detection can be analyzed depolarized laser light, and the third one can be that Bachmann filter ACC to detect the increases in the activated monocytes by its the 3 points are their volume, conductivity, and scatter. The sensitivity for this automated blood cell counters is very high, but the cost and the setting up of the whole system, it is quite difficult. One word about this microfluidic cell enrichment and magnetic resonance relaxometry detection. Again, a very promising application in disease biomarker. Again, a point of care testing element, but cumbersome and cost. Lastly, I have this Plasmodium specific phospholipases A2 levels in malaria. Nothing but this cytosolic PLA2s in, it is an acute phase reactant produced by host macrophage activation, and it is one of the marker for the inflammatory processes, and its level corresponds to generally the level of inflammation, generally the level of the disease can be diagnosed with this. Okay, beyond these molecular identities, I think we have this other tests like normocytic normochromic anemia, we have leukopenia, we have increased ESR, we have prolonged PT and PTT, we have electrolyte imbalances, we have hypergammaglobulinemia, we have metabolic acidosis. Very quickly, if I can just mention about the malarial vaccines, I think a couple of days back, India was actually congratulating everybody on this pre-erythrocytic vaccine, that is RTSS, which is available. It has completed the trials and will be available with us. And last but not the least, if I can say about the Rollback Malaria Initiative, 25th April is generally considered as the World Malaria Day, and India, along with NVB DCP, that is National Framework for Malaria Elimination Work, it started in 2016, and they have a vision of eliminating malaria by 2030. So we have this fingers crossed. Earlier it was 2003, then we had 2008, then we had this 2015. And the glitch was probably to 2020, we will be eliminating. So in 2016 only, they changed the shift, the paradigm was shifted, and the framework was named as NFME. And now we are looking forward, probably we have less of malaria and probably elimination of malaria, just like polio elimination in India. So this is all about malaria and the recent diagnosis with different molecular modalities. I think I have brushed up, but to me, the gold standard as a lab personnel, I think I will still count on light microscopy, the thick and the thin smears. Thank you.
Thank you very much, Dr. Bhamla. I think you had, like you said, malaria is one of the oldest and most documented diseases.
Thank you, ma'am.
Right.
So, like you said, it's one of the oldest and most documented diseases.
Right.
And yet, when we start talking about it, it still throws up new, what do you call it? New angles, new things about new ways of diagnosis. And we're not, I don't think we're anywhere near the end of the road, whether it comes to diagnosis or in terms of even, like you said, 2030 is the slated timeline for the elimination of malaria in India. I do believe our last speaker did mention that, one of our last speakers did mention that Sri Lanka has been successful in eliminating malaria, right?
Right, right.
So that did come up in Dr. Padma Shrikant's message in her speech, in her presentation.
Right.
Now, what do you think are the look? There are a lot of tests that you talked about, and yes, the gold standard is, as you said, the smear technique.
Right.
There's no discussion on that. I would say
Right,
at this
right.
point of time. But
Right.
from an Indian perspective, how much can we actually do? Into what tests would be fitting in with the kind of population we have, with the kind of incidence of malaria, and with the kind of skill set that people have with respect to going for microscopy?
I think conventionally microscopic examination at a simple, thick and thin blood smear, as I said, will be remaining as the gold standard. But for serological tests, they are actually useful, as I said in my slide also, they are very useful for epidemiological surveys, but they are actually not suitable for diagnosing acute malaria infections. So acute malaria, we have done molecular things, but that is epidemiologically for screening, for going in the fields, in the peripheries, it's practically not feasible with us. So serologically, if yes, sometimes the load is very, very less than 5, between 1 to 5 parasites per microliter of blood is there. So in that point of time, yes, we look forward for this molecular thing, but still, I think in a thin smear, you can still have a better answer than a serological test.
Right, ma'am. Malaria is not going away. In fact, I would venture to make a statement here that it's not, while it is a vector-borne disease, it's not limited to the monsoons alone now. Right. It's endemic throughout the year. I mean, as an organization that we are in the sphere of malaria testing, we with both rapid as well as ELISA tests, we do see that there is malaria prevalence across the country throughout the year. So do you think that's because of climate change that this whole change has happened, or what?
I think, sir, at this point of time with Omicron knocking at my door, as a microbiologist, if at all you ask me, many answers become very challenging to answer at this platform, sitting at a very strong platform. If you say that yes, it can be, then there can be a debate on two. I mean, it can be a 1 hour long debate. Yes, it cannot be. It can be. So at this point of time,
I just wanted to know your point of view on this. I doubt if I'm going to trouble you to debate with you on that topic right now. Just an opinion, because when we speak to medical practitioners such as yourself, who are at the front lines of fighting diseases, whether it's dengue, malaria, chikungunya, or COVID-19, we would like to defer to your judgment and your opinion in the matter. Helps people who are viewing this particular discourse. It helps them get a little sense of a clearer understanding, right? In the end, we are always looking, as diagnosticians, our objective always is clarity of result.
Exactly,
so anything that you can add is always useful.
I think to conclude, yes, light microscopy, but if given a chance, to my suggestion, I think I will go for PCR also as a modality for the higher things. Since I now coming from a medical college thing, yes, I can have that setup. And yes, this new word, when I talk about this RMOD, it is quite revolutionizing. Flow cytometry will be very, very helpful for a pathologist, for a microbiologist to use it. And we'll have answers within fraction of minutes. So if it is very easily available, just like next generation sequencing, which is available for other vector-borne diseases, if it's available somewhere in India, we can think about it. Because Abhi, the Western world is talking about it. In India, we haven't actually have theories to correlate with this RMOD.
There were a couple of questions that came in from the audience. One was, what is the best among PLDH and HRP2 for the diagnosis of P. falciparum?
I didn't get for falciparum, sir. HRP2.
HRP2, right?
HRP2 definitely, it is very, very helpful for the diagnosis of Plasmodium falciparum. In fact, some tests detect falciparum specific and pan specific antigens like aldolase and pan malaria PLDH also.
Right.
But it is just to basically distinguish between Plasmodium falciparum and the other non-Plasmodium falciparum agents.
How long do you think the parasite can persist its vitality in stored blood, especially when you're talking about transfusion medicine and blood banks?
Sir, exactly. The incubation period actually varies. So for different species, it can be different. It basically I think the question is, I really need to know about it, which speciation they are actually asking for it.
Okay, that our questioner has not specified that particular part of his question.
Yeah.
So I believe what would, if you were to give a ballpark figure in terms of a range, what would the range be?
So how long? Maybe 2 to 3 weeks.
All right. Okay. All right. Thank you so much, Dr. Bumla. It was a pleasure.
Thank you,
And
sir. Thank you so much. Thank
you know,
you, ma'am.
having the last presentation of the day is always, in my opinion, the most challenging, because you know, you come in at that at the end of the day and you have to get people up active again. And you know, we Indians or any other human beings, we love, after 3-4 hours of continuous debates and discourses, it gets a little difficult sometimes. But I guess you woke up a lot of people today, because you made them see that malaria has not gone away anywhere
No,
anytime soon.
I think this molecular modalities probably, because yes, as a clinician, as a microbiologist, I think I can say that yes, we know about, yes, the ring stage, gametocyte, chrysoid, this light microscopy we know about Buffy coat, we know about, yes, PCR. But itni sari molecular modalities और भी ज़्यादा हैं, and they're in the pipeline, so they might be thinking, no, where she is actually.
I am surprised, ma'am. I have been in medical diagnostics for over 1.5 decades now, and when you sent up all this data on molecular diagnosis in malaria, I almost had to go back to Google to check things again.
Thank you.
But thank you so much for your time, ma'am. And we have a gentleman in Bhatinda who will visit you very shortly to give you the actual certificate. But for the present, please accept this as a certificate of appreciation and our humble thanks for your time and effort, ma'am. Thank you, Dr.
Sir. Thank you so much. Thank you, ma'am.
Hi, Upasana ma'am. I have a question to you.
Yes,
May I ask?
Sure. Yeah, sure, please.
Ma'am, actually, I suffered with malaria a lot. A lot. It's been a lot during my education time when I was in hostel. It's like within every 2 or 3 months, maybe I have to go to the doctor to check my malaria. I don't know why it was happening, but it happened with me. Okay. So I have a question. Is there any way for extraction malaria DNA from whole blood? At that same
in fact, I will divide your question into 2 parts. You said that you had malaria very often. So I would narrate to you a very small story. In some parts of Punjab, yes, there were theories like there was I don't have to mention the person. The only thing, any person with fever, I don't know, agar us time pe COVID hota to wo kaise deal karte. But for every fever, that gentleman has been given chloroquine over years. Over years, he has given chloroquine to every fever, whether it's a viral, whether it is probably a malaria, which he never diagnosed anybody, or whether it is typhoid, whether it is any fever, means the poor chap has to, pop up with some kind of chloroquine to the person. So, madam, I really would want कि आपने अपना diagnosis करवाया था. It was by a microscopy or a serological test. If you remember, we can share it.
I just don't know. That time I was quite young, so and I was alone.
Most likely, ma'am, फिर microscopy हुआ होगा, and other times probably you wouldn't have had malaria. You would have had some other, infections. Okay. Coming to your next session, you were talking about what was the next question you had asked?
Malaria DNA, extraction of malaria DNA from whole blood. Sorry.
So that's what, ma'am. ये RMOD की जो मैं बात कर रही हूँ ना, that is very helpful for the whole blood. You can actually extract it. So if it is there in India, if that modality will be available in India with its hemozoin crystals crystallizing and finally extracting it out, probably it will be revolutionizing, but it will be expensive.
So then we don't have to take those heavy medicines for malaria, right?
In fact, the level, what I spoke about relapse and recrudescence, if you allow me to say for a minute, the burden of anti-malarial less treatment and relapse with that, it is quite high. And the artemisinin combinative therapy, we call it as ACT therapy, ACT therapy. वो भी आजकल उसकी इतना ज़्यादा resistance है, so you are actually not left with anything. And anti-malarial vaccine, how much it is going to be feasible, and reproducibility of that vaccine, it is still a challenge for India. So that's what, as sir said, the elimination part is still on a way more to go for 2030.
Okay.
Right.
Thank you, ma'am. Right. Thanks a lot, Upasana ma'am.
Thank you so much.
Now today we got very good knowledge regarding malaria also. Before that, dengue and everything, we are. I think we are knowledgeable today for for our self protection. Maybe we can protect ourselves with these diseases. And with the very knowledgeable session, we bring today's deliberations to a close. I'd like to thank you, Dr. Gaur, Dr. Shrikant, Dr. Shivade, Dr. Bhumla, for your time, effort, and knowledge sharing spirit. Thank you. And we would like to thank J.Mitra and company also. Arjun sir, Jatin sir, Dr. Neeraj Jain sir. Thanks to Believe Me. Thanks on Believe Me. It was a day with immense learning. Seriously, we at Tide hope that you also get knowledge by these sessions and benefited by it. And tomorrow, I'd like to say about tomorrow's session. So tomorrow will be a restricted gathering at Tide 2021. Tomorrow has been marked as CME, Continued Medical Initiative, organized by MILAP. MILAP is Medical Education and Learning Point. So if we are looking forward to reconnect tomorrow, you have to register with CME, as already Arjun sir told you and gave you a session to give you an option to give your mail ID to him, and he will send you. I think I'm right, sir? Arjun sir?
Two things. Any participant here can register for the CME provided they are a medical practitioner, a doctor, because under the Medical Council of India, the CME held under the aegis of MILAP will be giving 1.5 hours of CME points. And if you go through your chat screen, you will find that I have shared the link to the registration in that particular chat screen itself. So we have a lineup of some very important doctors coming in tomorrow, and they will be speaking on varied topics. So I think this is going to be a very good idea. It's one of the very few times that MCI has given an approval to MILAP to do online CME with points as well. So please use this opportunity. From us at J.Mitra, thank you very much. We wait for one whole year to get back on this platform. We do scientific seminars from time to time online, but for us, TIDE is a coming together of a lot of minds and doctors, and it is our initiative. It is the initiative of Mr. Jatin Mahajan, our managing director, and under his guidance, we have developed this particular platform. It's one of a kind in this country, and we look forward to the round 3. Hopefully next year will be bigger than the one gone by, right? Thank you.
Yeah, thank you.
So much.
Thank you. The last I would like to say you is smile is a good reply for the dark world. As Upasana ma'am always have a very good smiley face. So we also should be like that.
I take it as a compliment. Thank you so much.
That
You made my evening, in fact.
Thank you, ma'am.
Thank you, everybody.
Take care all. Thank you. Thanks a lot.
We'll see you all doctors tomorrow afternoon, 2 o'clock for the CME. Thank you.
Thank you. Thank you all. Thank you. Thank you, sir. Thank you all. Namaskar.